As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care for you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure control, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that of course she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed, that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie. Good morning, Sophie. Hello. How are you? Well, now we'll do the round all together, in which we discuss your improvement and the goals for today. Okay? All right.
Good morning. So, Massimiliano, what can you tell me about Sophie?
Well, Sophie has been with us for 3 days now, and she has been here for a septic shock. I think her condition is generally improving. Her drug levels are going down, and also her organ function is improving.
How about the kidney?
The kidney are also going better, and she is able to have a good urinary output on herself. I think also we are on the 3rd day of antibiotic therapy, and the condition is generally improving.
Okay, and the antibiotics are correct?
Yes, we have identified one bacterium on the blood, and the antibiotic therapy is targeted on that.
Oh, perfect. Alessandro, anything from your side?
Well, during the night with a very, very light sedation, she slept well. She's comfortable. Now, no pain, actually, and a good bowel partner now.
Okay, perfect. So I would say we try to switch off the medication today.
Oh, completely? Okay.
Yeah. And then also later today, we will try if we can get her off the breathing machine and put the tube out. And
Wonderful.
before that, perhaps, Victoria, can we try to sit her at the edge of the bed?
Yes, I think we can try. Yesterday she was able to move arms and legs by herself, so why not?
Okay. It will be a little bit tough for you, but I think it's important. So the physiotherapy will help you to sit at the edge of the bed, and then we will see, yeah? And later on, we will try to get the tube out as well. We have no nutrition yet, but I think that's fine since we are improving anyway, and then perhaps we can try after the tube is out to start with normal food. I read something about family issues.
Yes, she had a complicated family situation, so I think it could useful call the social assistance for the roundtable. Yeah.
Okay, Massimiliano, you will handle that?
Yeah, I will call the social assistant today and see what we can do on that.
Okay.
Okay, perfect. This was the very important interprofessional ward round. There, we discuss important information between the healthcare professionals of the ICU team. Furthermore, we discuss the goals for the patient of the day.
Communication with caregivers is one of the most highly valued aspects of care. Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow. Research has shown that families get frustrated or confused when clinicians use medical terminology or abbreviation without explaining them. Also, they get confused when they receive information from too many different clinicians. So don't hesitate as a family member to ask questions, to ask the nurse or the doctor to repeat the information, and more generally, don't hesitate to ask for a meeting with the ICU team.
Hello, Sophie. I'm your physiotherapist. Today, we're gonna try to put your legs out of the bed and to stay sit. We're gonna do that together, me and your nurse, okay? Let's try. Okay.
So, we check the length of the tube. Please check the length of the lines.
Everything's okay?
Okay.
Okay.
Well,
So,
together.
we can start. Come here with your legs. Okay.
Oh, good.
Sounds good. Okay. Okay. How are you, Sophie? Is it comfortable for you? Okay. Let's breathe normally.
Perfect.
Okay.
Pain? Okay. Small breath? Okay.
This step is very important for the weaning of the tube. Okay? Okay.
This collaboration between the nurse and the physiotherapist is a key feature for the best outcomes of the patient. And together we get off of the bed and sit Sofia on the bed.
Hi, Alessandro. How was your shift?
Hi, hello, Delia. Well, Sophie, all right.
She's awake today.
Yeah, she is. Well, morning shift was very good. We decreased all artificial supported, and now she goes very better. The goal is to remove the tube, so stop the ventilation by this evening.
Oh, nice.
Yeah.
Were you able to have a physiotherapy session?
Yes, this morning we put the leg outside the bed and she was good.
Okay.
Is it?
Perfect. So, Sophie, I am going to take care of you for the next few hours and we are going to remove the tube. Are you happy? So you are going to be able to speak again and we can hear your voice again.
Okay.
again on Tuesday. I really hope you had a very nice day. Yesterday, Monday, the first day of our Congress, where you have seen some of the new features that we had. I hope you have participated in the groundbreaking release session, and in a minute we will have the second groundbreaking release session. I would like to put some attention on the case-based sessions, which are part of the educational channel. So what is the case-based series? What can you learn there? Well, what will be done is that a real case will be discussed, and after some information it will be stopped, and then all the features of the patient will be discussed by experts. So that means that part by part, just like in real life in a patient, you will have a lot of uncertainties in the beginning, a lot of missing information in the beginning, and the information will come slowly to you, and then you will discuss the differential diagnosis, what you would do, and this is all discussed also with you by experts in different fields. I think so, a very realistic, and well, it gives a lot of fun to participate in that. And if you want to have a chat with our ESICM president, Maurizio Cecconi, why not do that? Today you have the possibility. And you can have a chat with him and ask him all kinds of questions that you want to know about what his work looks like, how it is to be the president of the European Society, how can you become the president of the European Society, all kinds of questions you can ask to him. If you're interested how you should lead a very big intensive care, why not chat today with Claudia Spies from Berlin? She has a huge experience in leading an intensive care, and you can find out how they do that in Germany. That can be different, of course, from your own country, but that is not of very much importance because it gives you new information and perhaps it gives you a lot of inspiration as well. Well, a lot of you are also working on publishing and getting papers published, and this for you is an ideal situation to talk to Giuseppe Citerio. He is, as you know, in the lead for our journal, Intensive Care Medicine, and well, if you really want to know the important things, how do you get your paper published, apart from, of course, that it should be very good, but there is more to that, and these are the kind of questions you can ask him. And if you want to know every detail about frailty, why not chat today with Susanna Lever? And if you want to know something about what you should do about errors in the ICU, we know every day we make errors, and in fact, in my view, the art of intensive care is to make as few errors as possible, and you can have a chat with me. We will have again the educational course, and this time in English and in Spanish. I really hope that in the near future we will also have an educational course in other languages than we have presented this year, but we will also have a look how well this is appreciated. Roundtable sessions and forum sessions give you the opportunity very much to discuss in a very open way. Spontaneous questions, you can directly communicate with how the speakers talk about this subject. It is not with a smooth slide presentation, and it gives you the possibility, well, to learn the things that you probably won't read in the scientific papers. If you want to know something about what you should do with an ICU database, or if you want to know everything about obese patients, very important subject, and it is a lot of things are really different in obese patients compared to non-obese patients, and especially during this COVID pandemic. You all know how important it is that we know how to deal with the obese patient, that we choose the right doses of drugs, etc., that we take into account of the distribution volume, and these patients can be different. Well, if you want to take a deep dive in this subject, do it today. We also will have the presentation of the best oral, of the best abstracts, and this will be presented as an oral presentation. So it's very good to know what our young colleagues are doing and how they present it, and see what kind of questions it raises in your mind. Well, you know, we have had this year a datathon of the data science group section, and the winners of the ASICM datathon will present their abstract, their presentation today. And finally, again, at the end of the day, I will make it very easy for you to find out what the chairs of different sections found most important today. And I will speak today with the section chairs of ethics, and the chair of the infection, and the chair of the systemic inflammation and sepsis, and the section for translational biology. And, well, this will give you a good idea, and they will probably select for you what is most interesting according to them for you. So make your choices again today, and I know the most difficult thing for you during the Congress is to make a choice, because there is really so much to do. But remember, if the Congress is not running anymore, you will still have the possibility to watch all the videos on demand, but also all the registrations of the different live sessions that have taken place. So enough to be busy for the next couple of weeks. And I really hope you have today a very nice day.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning, everyone, and welcome again in Lives 2021. I'm delighted to share this groundbreaking session with Professor Jufferman from Amsterdam and Professor Citerio from Milan, and you already know that both of them are the editors of the ESICM journals. This morning we are delighted to introduce a very, very important study that has been selected by Intensive Care Medicine and Giuseppe Citerio and his team, and will be presented by Pierre-François Laterre from Belgium and Alexandre Mebaza from France. This study is a very important step from understanding pathophysiology mechanism to going and treat a specific disease, in particular here septic shock. And I'm very, very happy to introduce both Professor Laterre and Mebaza to present the Adrenal 2 trial.
Hello, ladies and gentlemen. It's my pleasure, together with Pierre-François Laterre, to present the Adrenal 2 phase 2 biomarker guided trial. The results of the trial are published at the same time in intensive care medicine. Adrenomedulin is known since many years. We are measuring it in our patients. It's a protector of endothelial barrier. Here you see that adrenomedulin is in the lumen of the vessels, and it's improving vascular integrity. In sepsis, adrenomedulin is increasing in the lumen of the vessels, but also in the interstitium, and it is inducing a vasodilation by its effect on smooth muscle cells. Here in this trial, we are testing the safety and efficacy of an antibody that is modulating the effect of adrenomedulin. This is adresuximab. Adresuximab will bind to adrenomedulin And as we will show in our study Adrenos 2, we are showing increasing evidence that this adrenomedullin in the lumen is in fact aspirated from the interstitium toward the lumen. Here is the concept behind Adrenos 2. There is infection and systemic inflammation, a loss of integrity. Bio-IDM is increased, and then we're using adresuximab, which again is an antibody modulating adrenomedullin pathway. The population we are targeting is a population with a septic shock, indeed, with a bio-IDM greater than 70 picogram per milliliter. And we know that in those patients with a high bio-IDM level, they can go towards shock, organ failure, and possibly bad outcome. Here is the design of the trial. First, and this is very important, we selected patient early after the initiation of vasopressors. Then really when the patient was admitted in the ICU with vasopressors on board, the whole procedure should be finished and the drug should be given before 12 hours. Bio-IDM higher than 70 picogram per milliliter, as we said, and this is measured on site or most often. And then we call the CCC to check whether we have all the eligibility criteria. And then the patient is randomized in 3 arms: adresuximab 4 milligram per kilo, adresuximab 2 milligram per kilo, and placebo with a ratio of 1, 1, 1, and 2. And then we were checking 40 days and 28 days outcome. Here is the patients. We screened a high number of patients. 158 were non-eligible, mostly because bio-IDM was below 70 picogram per milliliter. Then the intention to treat is 301 patients, as we said, placebo 152, adresuximab 272, and 477. Then the ITT is 301 patients. Here is the primary safety endpoint, and as you would see in a minute, adresuximab demonstrated no harm in both doses. Here we have the analysis of the treatment emergent adverse event. This is serious, those leading to death and those related to the drugs, and you see that there is no difference between placebo and the 2 doses. Then we can say that the single dose demonstrated of adresuximab demonstrated no harm. Now we had a primary efficacy endpoint, the SSI, and various secondary endpoints. Let me show you first the results of SSI. No difference between the combined 2 subgroup receiving adresuximab and placebo concerning the SSI. And when we looked on one of the secondary endpoints, the change in SOFA, as you can see here, the red is the placebo, the blue is the adresuximab combined, and there was a difference along the 5 days, and this difference was also statistically significant at 24 hours. Now, when we looked at 28 days mortality, there was no difference. You see the mortality in the placebo arm was 27.6 and 23.5 in the adresuximab arm. Concerning pharmacokinetics, as I told you earlier, we could confirm the mode of action of adresuximab. First, here we show you the concentration of the antibody over the study period, and you see indeed that the patient receiving 4 milligram per kilo had a higher concentration of adresuximab during the study period. Now, when we measured bio-IDM in the plasma, you see that here again, the more there is antibody, the higher is the bioadrenomedulin concentration. It's also high at 2, it's even higher at 4 compared to a placebo. And this increase in bioADM is really due to a change, a translocation from the bioADM from the interstitium to the lumen. And why can we say this? Because when we measured the newly released or produced ADM, and this is MR pro ADM, you see that there were no difference between the 3 arms. Then really the bioADM that was highly present after the administration of adotiximab is related to a switch from the interstitium to the vessel.
So to summarize the data presented by Professor Mebaza, the primary endpoint of Adrenos 2 study was met. In other words, the drug was well tolerated and showed a favorable safety profile. In terms of efficacy outcome, the adotiximab demonstrate a trend towards reduction in mortality, but mainly demonstrated significant improvement in organ dysfunction. Also, the mode of action was confirmed. There was a significant increase in the plasma bioADM supporting the suspected mode of action. So therefore, there's a solid base to move forward in the development of the use of this antibody in septic shock. And future study, this will be discussed later on, will be selected based on a biomarker-guided patient selection. So Adrenos 2 provides the basis of the future clinical trial in this setting. So to summarize the data presented by Professor Alex Mebaza on Adrenos 2 trial, we can say that the primary endpoint was met. In other words, the drug was well tolerated and showed a favorable safety profile. In terms of efficacy outcome, adotiximab demonstrates a trend towards a reduction in mortality, but mostly demonstrated a significant improvement of organ dysfunction. Also, the mode of action was confirmed, as long as we've seen that there was a significant increase in the plasma bioADM in patients treated with the drug, and confirmed the suspected mode of action. So there's a solid base to further develop now adotiximab in the setting of septic shock, and future trials will guide and select a patient based on a biomarker-guided approach. So we therefore have a proof of concept in septic shock. It has been shown here that the use of adotiximab in septic shock was safe and well tolerated. Interestingly, the mode of action seems to be confirmed by the elevation of plasma bioADM in the serum. Also, an improvement in organ dysfunction that is quite sustained. And we need now, in the future development, demonstrate that there's a survival benefit in the patient treated. Therefore, the program Encourage 1 will include patients based on the presence of elevated biomarker, in other words, bioADM, and a low level of DPP3. This will be later explained. The proposal of selecting patients based on these 2 biomarkers is driven mostly from a post-hoc analysis of the Adrenos 2 study. Patients there were included based on elevated bioADM and the presence of shock, but additional determination were performed in these patients, and DPP3 was measured, and we'll see the role of DPP3 in worsening the hemodynamic condition, and therefore help in selecting the target population for the next study. The slide here summarizes the role of DPP3 in the setting of critical illness. In normal condition, DPP3, which is a peptidase normally stored in the cell, is not interacting with angiotensin II. But in the context of septic shock, with cell damage and cell deaths, there is a release of DPP3 into the circulation, and this peptidase will then inactivate angiotensin II, leading potentially to a certain degree of cardiac depression. When we looked at the observational study Adrenal 1 and separate patients according to the level of DPP3 at baseline, using a cutoff value of 70 nanograms per ml, you see the survival curve and a dramatic difference in the outcome and the mortality at 28 days. If the same cutoff value of DPP3 is used in the population enrolled in Adrenal 2, so taking the intention to treat population and extracting the patient having a DPP3 value at baseline below 70, we did end up with roughly 90% of the patient of the ITT that was used for this, and you see that the improvement observed in organ dysfunction is even further amplified, and you see on the left part the change in the SOFA score over the first 7 days. At the same time, when you look on the right part of the panel at the mortality curve, the difference in between the placebo and the treated arm was further increased with an absolute reduction of 8%, even though this did not reach statistical significance. Therefore, all these elements support the development of the program ENCOURAGE trial. This is the acronym of placebo-controlled, double-blind, randomized, multicenter, biomarker-guided phase 2b clinical trial to investigate the efficacy of adretitumab, now called enibarsimab, by the request of the World Organization. So in the treatment of endothelial barrier dysfunction in early septic shock and to restore vascular integrity in these intensive care patients. The concept of ENCOURAGE trial is, of course, a tailored population and precision medicine approach using biomarker guiding the selection of patient to identify the patient that potentially may most benefit from this intervention, excluding patients with very elevated DPP3 because we know that they have a poor outcome and are not a target for the antibody, and select patients rapidly after the onset of shock, and you'll see that the target is to have these patients enrolled within 8 to 10 hours after the start of vasopressor, combining there the presence of elevated bio-ADM and a low DPP3. So ENCOURAGE 1 trial is summarized here, especially the key inclusion criteria. Patient will require to have septic shock, being treated early with the antibody, so within 8 to 10 hours after the start of vasopressor. We'll need to have a bio-ADM that is elevated like in the previous study, so above 70 pikes per ml, and a DPP3 level this time below 50 nanograms per ml. Randomization is 1-to-1, and then this time the primary endpoint efficacy will be 28-day all-cause mortality. Patient will be followed until day 90, and additional secondary endpoint will remain, in other words, the change in the SOFA score, but also the length of stay in hospital and in ICU, and the fluid balance and the requirement of vasopressor. The estimated population to be enrolled goes from 860 to 1,000. So once again, ENCOURAGE 1 trial summarizes the concept of precision medicine in acute care by the use of biomarker-guided patient selection, as you've seen previously, the role of bio-ADM to target pathophysiology, but also DPP3 to exclude patients that we know have a poor outcome, and to have patients treated as early as possible. The sample size has been estimated based on pre-specified DPP3 level, and the primary endpoint, as we've said, is 28-day all-cause mortality. Finally, this presentation comes together with the release of the results of the Adrenal 2 trial in intensive care medicine this week, and this will provide you additional information and details on the Adrenal 2 trial. Thanks for your attention.
Thank you very much for this excellent and very insightful presentation, and I would like to congratulate Professor Laterre, Professor Mebaza, and all the co-authors and the working groups for providing us with such a very important aspect of precision medicine, getting, it's not a new target, but a new way to target the endothelium in septic shock. I'm just going to ask you a question before getting to Professor Chiterio and Professor Huferman. My first question is about inclusion criteria for the next steps. So you have learned a lot on how how the targeted therapy is effective not only in the global population but also in subgroups. Are you going to change the inclusion criteria or maybe stratify based on DPP3 for the next steps of the study? For Encourage.
Yeah, if I can answer, Alex, definitely the way patients are going to be selected is a combination of elevated bio-ADM, so above 70, and a level of DPP3 below 50. So in other words, when you have a very high level of DPP3, you know that the outcome is very poor and the likelihood to be influenced by a drug is small. And therefore, we're going to be in a population in between the one definitely known to die and the one definitely known to survive. So just in the middle by selecting and using these two biomarkers.
Thank you, Pierre-François. Giuseppe Chiterio, you're the chief editor of Intensive Care Medicine. Can you tell us more about the process, the article, the first time you looked at that on your computer, and how you translated that into this very, very important success?
I think we started to discuss internally if the manuscript was interesting for the clinician, because we are a journal devoted to clinicians and we want to send to clinicians some clear messages. And I think that work presented today is quite important, because we started to understand that we can target the population we are treating, because we already had a lot of trials without any success, any benefit for patients, probably because we had too broad entry criteria. And the question for the authors, I think that the stratification is a crucial point here. How can you imagine this process of stratification of the patient at the bedside in the future if the next trial will succeed in demonstrating a benefit in this approach?
Yeah, if I can take that question first, on behalf of Pierre-François and the co-authors, really I would like to thank the editor-in-chief and really everybody in intensive care medicine, because I can tell you the reviewers and the associate editor who took care of the journal helped us a lot improving the paper. I can tell you that the initial version of the paper and the version that is now out was markedly improved, and really thank you to the reviewing process. Now, concerning your question, I think for years, Pierre-François and myself, we were doing many trials, and for years, all the investigators, everybody was saying, Alex, it's impossible to stratify with biomarkers, because when the patient arrives, we are so quickly taking care of him or her. We are doing so many things. It's really impossible to add the biomarker measurement. And I think maybe this is, at least for Pierre-François and myself, maybe the main message here is that we succeeded to have a biomarker guided trial within, in fact, a median of 8 hours, which is not a lot when it is in the middle of the night. And as you know, septic shock often arrives in the middle of the night or during weekends. In 8 hours, we succeeded to have approval, measure bio-ADM, call the CCC, and have the trial successful. And I think for me, it's one of the important points. It shows that, as you said, we can And I hope we open the door to many other investigators of the world to say we can stratify, we can use biomarkers to stratify. And the other point, but I will let maybe Pierre-François elaborate, is that patients for whom investigators thought they are in septic shock, with no doubt, and they would have included them in any septic shock trials, when we measure bio-ADM in 1 quarter, Pierre-François, if I'm not mistaken, 1 quarter, bio-ADM was below the threshold and their outcome was different. Maybe Pierre-François, you can explain better this discovery, in fact.
Yes, Alex, this is not, of course, published here for the moment, but by using the biomarker, we in fact demonstrate that using usual criteria, so the clinical definition of septic shock together with elevated lactate, you may end up with a proportion of patients, despite having the criteria, having a low bio-ADM, so below 70, and their outcome was completely different because the mortality was around 10%, which is, of course, definitely different from the population we've selected here. So in the past, keeping and using the classical definition, even sepsis-3, to select a population is not sufficient to target a population at risk of death. And therefore, it's also important to not only guide the therapy on the biomarker, but demonstrate that your population is potentially the target and that your drug will influence the outcome.
Thank you very much for your answer. And I think that what you said, Alex, the journal is trying to do the best for improving the paper. We try to be fast, but also to increase the quality. The work was excellent, but probably we work together for having a better manuscript to be published for the community. And I give to Nicole to comment on it.
Yes, and also for me, big congratulations on this exciting trial moving towards precision medicine. Allow me to ask about the use of the measurements of this bio-ADM, and you propose to add another measurement of another biomarker. Do you think that this can be easily done in terms of implementation? Let's say your trial will be positive. Can all the hospitals really measure this? Is there a point of care coming up? Please elaborate.
Pierre-François, would you like to start, and then I will,
Yeah, I mean, this is really a key question for the future, but not only for the study, for the future. There's an ongoing development, and normally it should be ready within a couple of months, to have a bedside assessment and a point of care, combining the determination of both bio-ADM and DPP3 within an hour. So it's going to be a rapid way to select patients for the study and for the treatment if it works. Alex?
Yeah, but you're totally right. I mean, this would not work if we don't have a point of care. Now, in this study, it took us roughly 1 hour and something, between 1 and 2 hours to do bio-ADM because the system was really in the beginning. Now, indeed, because we showed successful and the company invest money, now probably the next step for Anchorage that Pierre-François showed, we hope that the 2 biomarkers can be measured really anywhere in the world with an easy system, less than, let's say, between 20 and 30 minutes, which is, then we would save 1 hour probably compared to the Adrenos 2, and probably there's a reason why in Anchorage we are putting, in fact, 2 challenges. One, as you understood, it's going to be a dual biomarker-guided therapy. And 2, we are going to try to have the patients included within 10 hours and not 12. I think all intensivists would agree that the sooner the better.
That is excellent news. And then to dive a little bit deeper into these biomarkers, is there any reason to assume that a high or a low level of bioadmin really represents different populations, or is it just related to disease severity?
I will say that at least this is a witness of the disease severity if we just correlate the value of bio-ADM and the outcome. This had been shown in the first observational study we did, so Adrenos 1, showing clearly a difference according to the cutoff value. Now, does it mean that the population is different? It's too early to answer this question and see whether these are different patients compared to the one with elevated bio-ADM. The future will help probably, but at least, as I said before, despite a similar clinical picture of shock, bio-ADM correlates outcome and therefore remains a way to target. The future will also help us to see whether they have a different genotype or phenotype and not just a witness of severity.
Well, that takes us to another very important perspective. Alexandre, Pierre-François, can you tell us more? We have young investigators listening to us this morning, and you are worldwide experts in the field of biomarkers, and then taking from the pathophysiology, identifying pathways, and now getting to a personalized approach for therapy in septic shock. Can you tell us more about the history when you started working on bio-ADM? I think that it's important for the young generation to understand how long it took to you to not only understand, identify, develop, validate, and get to trials, clinical trials. We are very interested to listen for that in the 2 minutes that are left.
Yeah, thank you, Eli. In fact, everything started in my INSERM lab in our preclinical research with a fellow that you know, Alice Blay. She did the first experiments. Really, we did it by, in fact, because we thought that the concept of biomarker should move us to biotargets, because I think we were all fed up knowing, as we heard, that the higher the worse. I think after 3 biomarkers, I think you got the concept. Now the idea is to see how you can modulate. And in the first experiment in rats, in septic rat with CLP, we saw some positive results. And Peter Pickers in Netherlands showed really beneficial effect in the phase 1. And then the company agreed, and we had a long discussions to really, with Pierre-François, to push, saying we need to include the patient as early as possible. We need, even if it's tough to measure biomarker, we need to measure biomarker and not give the drug to anyone, because really the way to go until now is just give the drug and see. And I think they were, they agreed with us, and here we are.
And how long from the initial identification? 5 years.
5 years, 5 years, first injection in rat until today.
Well, it's time now to congratulate you again, the two of you and all your group and all the scientific people involved in the studies. Congratulate ICM for having picked this paper and provided it at Lives 2021. And we look forward to have more experimental data from this study that could be submitted to ICM Experimental, the other ESICM journal. I wish you a very good Lives 2021. Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Because your patients can't wait. Because your mission is to buy time and save lives, we are here. To face emergency, we have adapted our manufacturing facilities. We are here to support you, offering access all around the world to the latest articles and sharing recommendations from the most experienced experts. Assisting the ICU community on how to manage critical patients is always our priority. Aspen delivers more than anesthetic products. It is because you are there for your patients that we are here for you.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
Good morning, everybody. This is the next series on best oral presentation, number 3. And I would like to introduce Jan de Walle, my co-moderator. My name is Frankie Duška, and I'll be happy to talk you through this series of 5 presentations. So, without losing any more time, I would like to introduce Dr. Veblen from Birmingham and his talk on ICU-acquired weakness and prediction of patients' discharge destination. Dr. Veblen, please.
Good morning, my name is John Weblin. I'm a consultant physiotherapist within critical care at the Queen Elizabeth Hospital in Birmingham. And I'm here to talk about a prospective observational study looking at ICU-acquired weakness as a predictor of discharge destination in patients admitted to intensive care with COVID-19 requiring mechanical ventilation. Intensive care acquired weakness is a common complication in patients admitted with COVID-19 requiring mechanical ventilation. Previous studies have shown ICU-acquired weakness to be associated with greater functional impairment in survivors of critical illness, necessitating the need for ongoing rehabilitation both within hospital and following discharge. Little is currently known regarding the impact of ICU-acquired weakness on recovery and rehabilitation needs in survivors of COVID-19. Our objective was to ascertain if the presence of ICU-acquired weakness at ICU discharge could predict hospital discharge destination within this cohort. Adults admitted to a large UK ICU between January and March 2021 with a confirmed diagnosis of COVID-19 and mechanically ventilated for greater than 24 hours were included in analysis. Patients with known neurological insults were excluded. The presence of ICU-acquired weakness was assessed using the Medical Research Council sum score at ICU discharge. This is a validated outcome measure within this population and assesses muscle power within 3 muscle groups within the upper limbs and lower limbs on a scale of 0 to 5, 0 being complete muscle paralysis and 5 being normal muscle power, giving a total score out of 60. Those scoring less than 48 were classified as having significant critical care required weakness, and those scoring 36 and less severe. Hospital discharge destination was characterized as either home with rehabilitation, or inpatient rehabilitation. 117 patients were analysed, of which 60 presented with ICU-acquired weakness at ICU discharge. The development of persisting ICU-acquired weakness was associated with longer periods of sedation and mechanical ventilation and longer lengths of stays in both ICU and hospital. Patients were also slower to mobilise and had lower mobility levels at both ICU and hospital discharge. 87% of patients who were found to have ICU-acquired weakness at ICU discharge required ongoing rehabilitation either at home or as an inpatient, compared to only 28% in those that didn't. A further sub-analysis demonstrated patients with severe ICU-acquired weakness were significantly more likely to require inpatient rehabilitation. In conclusion, patients admitted to ICU with a diagnosis of COVID-19 with ongoing ICU-acquired weakness at ICU discharge are significantly more likely to require ongoing rehabilitation either at home or as an inpatient than those without. Routine screening for the presence of ICU-acquired weakness could therefore help manage patient expectations, allow pragmatic and early discharge planning, and provide an objective measure for rehab physicians to utilise and predict recovery trajectories in patients with COVID-19.
Okay, thank you very much. Do we have the speaker online? Okay, hello. Good morning.
Good morning.
Good morning. I just wanted, before we start asking questions, I just wanted to urge everyone to use our chat function and use the opportunity to challenge our speakers with questions. We will be happy to take it for you. Okay, thank you for excellent presentation.
No worries.
I'll be happy to maybe fire a first question at you, Dr. Webb. And of course, we've all seen that ICU-acquired weakness is very important in COVID-19 patients. Now, if I see it correctly, and forgive me for not counting the waves in the UK, but this comes from the second or third wave. Did you see any differences with the first wave or what came after that?
So this was our third wave as such. No, so we published some previous work looking at functional outcomes for patients in wave 1, and it was a very similar picture. Patients were leaving ITU with ICU-acquired weakness, and that's basically because the management of these patients hasn't changed. We know that they needed high levels of sedation, prolonged periods of mechanical ventilation, and as a result of that, they led to ICU-acquired weakness. So very similar.
Relation with the lack of qualified personnel, nurses, physiotherapists during that wave? Any way that the strain on the system actually played a role in that?
Yeah, we're very fortunate that we have a very well-established physiotherapy service within our intensive care. We've published a lot of work looking at the importance of early rehabilitation. So we do have a culture of early mobilization, and as a service, we were very well supported. We did offer a 7-day service during the first wave because we had redeployed staff. But during the third wave, which was where this data came from, we were only able to run a Monday to Friday service to offer rehabilitation. And we did see that as a result of that, patients were slower to mobilize. So wave 1, we were seeing all patients within 24 hours of coming off sedation, whereas in wave 2, we were seeing them within 48 hours, and our patients were leaving slightly functionally worse.
Okay, thank you very much.
Thank you. Thank you so much, Jonathan.
Thank you again. Congratulations on your presentation. I think it's time to move to the next presenter. It's a pleasure and an honor for me to introduce Dr. Sanchez Ramirez. She will be presenting on the long-term application of selective digestive decontamination in a mixed ICU and the impact on nosocomial multi-resistant infection, antibiotic consumption, and colistin and tobramycin colonization. Again, if you have any questions, make sure to send them through the application, and we'll be happy to put these questions to the presenters.
Good morning, my name is Catalina Sanchez. I came from University Hospital of Gran Canaria, Dr. Negrín, Las Palmas de Gran Canaria, Spain. I would like to present our findings in long-term application of selective digestive decontamination, SDD, in a mixed ICU. Impact on nosocomial multi-resistant infection, antibiotic consumption, and colistin and tobramycin colonization. We have no conflicts of interest, and our conclusions were: after long-term application of SDD, 8 years and 9 months, a significant reduction of nosocomial infections by ESBL, multi-resistant gram-negative bacteria, and Acinetobacter were found. Also, a significant reduction in ventilator-associated pneumonia, urinary infection, secondary bacteremia, and multi-resistant nosocomial infection rates. An important reduction of antibiotic consumption was found after SDD also, and low rates of colistin and tobramycin-resistant colonization. 8,325 patients were admitted to our unit. We apply SDD to patients who require mechanical ventilation longer than 48 hours. We compare two groups, one group without SDD, 1 year, to a group, SDD group, 8 years and 9 months. We collected patients with nosocomial infections. The multivariate regression analysis showed us that Acinetobacter infections were significant with a odds ratio less than 1. Looking at the nosocomial rates in Table 3, ventilator-associated pneumonia, urinary infection, secondary bacteremia, and multi-resistant germs were significant with a reduction after SDD. But look at the multi-resistant germs, Table 3, which is from 9.5 without SDD to 2.4 with SDD, and the relative risk was 0.26. Also, patients with infection by ESBL or multi-resistant gram-negative bacteria were significant and lower after SDD. No infections by Clostridium difficile was found. Antibiotic consumption was low after SDD, as you can see in the picture, and we had low rates of colistin and tobramycin-resistant colonization. Take-home message is SDD is safe and useful to reduce multi-resistant nosocomial infections in places with high level of antibiotic resistance. Thank you very much for your attention.
Thank you, Dr. Sanchez, for presenting your data, and welcome. We have a number of questions for you.
Catalina, hi. Thank you and congratulations on your nice presentation. The only thing is, can you talk us through the methodology? I mean, how did you select the control group? Because, what decided, because this was not a randomized study, was it? So what decided whether the patient received the decolonization or standard of care, and also what the standard of care was? So which kind of other precautions against nosocomial pneumonia do you routinely use in your unit?
Well, if you look at the table 1, we compare two groups. One group begin. Are you listening to me? Yes. One group was collected from October 1st, 2010 to 30th to June 30th, 2011, 1 year. And after that, we began SDD. It's not a control study. It's just before and after. No? We apply SDD from October 1st to September 30th, 2011.
So, sorry, because we had some echo, just to make it clear for everyone, it was a before-after study. You use the You checked it and then you implemented the SSDD and compared before and after implementation. Thank you very much. And coming to second question, what kind of precautions against VAP did you use? So, because if you want to implement it on your unit, it would be nice to first make sure that you do simple things right at the first place. So what kind of precautions against ventilator pneumonia do you use in your unit?
Well, first to begin with the SD, we apply every maneuvers that were described by many papers. No? We apply SD. And we were in pneumonia zero, program, a Spanish program, who hotline many ways to avoid, for example, in this case, nosocomial pneumonia. But we had, as you can see in table 3, we have rates about 10.3. Even we apply everything. So we apply SDD after that. And of course, we have to look for many things, no?
Okay.
Everything has been.
Thank you so much, Catalina. It was a really nice presentation. We have no time for further questions, so I have to move on and invite Dr. Inchas from Lyon, France, with his presentation on the development of a vectorized interleukin-7 immunotherapeutic to stimulate innate and adaptive immunity for the treatment of sepsis. So, Dr. Inchas, the floor is yours.
Good morning. It's my pleasure to introduce today the development of a novel immunotherapeutics addressing the immunosuppression status of sepsis patients. Sepsis is a complex disease. We know that patients who survive the first phase of infection will, for the majority of them at least, enter a phase or status of immunodepression which is long-lasting and eventually will jeopardize their survival. Only a handful of immunotherapies are addressing this positioning today. They're based on soluble molecules, targeting innate pathways or adaptive immune systems. We have developed an immunotherapeutics aiming at targeting both arms of the immune system in a single product. For doing so, we have used a viral vector, which is well known, the MVA vector. It is non-propagative, non-replicative, used in many immuno-oncology trials, and has a capacity, which is the interest here, to stimulate many pathways of the innate immune systems. This vector is expressing an IL-7 linked to an FC receptor, and we have developed a package supportive to clinical development. On the next slide is shown the mechanism of action of this vector. By using the IV route, the MVIL-7 will infect different organs of the host, including the liver and the lung, for example. The cells are going to manufacture an IL-7 which is going to be released in circulation and trigger or stimulate different cells of the immune system here, including, of course, T cells. But in addition, the MVA backbone will sense innate immune system in different ways, and the sensing of innate immune system will complement the earlier mechanism of action of the IL-7. So on the next slide is a key finding of the studies by using in vitro and in vivo mice, sepsis naive or non-human primates, testing the MVA-IL-7. We've shown the product is active. There is a favorable pharmacokinetics for the IL-7 FC which is produced. We know we can increase number of cells of the immune system, not only T but others. In particular, the product is very efficient at activating those cells, inducing a differentiation status, and even triggering production of different cytokines by T cell, in particular interferon gamma 1. We've shown a protective efficacy in different models, and interestingly, we performed side-by-side experiment with a soluble IL-7 FC counterpart. Showing here is an example of these comparative studies, where the products have been injected in mice, CLP mice, at time of immunodepression here, a single injection for each of them. We looked at the expression of IL-7 in circulation, the detection. We see a great increase when the IL-7 FC is used compared to the soluble cytokine. And when we analyze CD8 T cell expressing interferon gamma IL-2 or triple producer here of cytokines, we see a nice advantage for the MVIL-7 too. But I thank you for your attention.
Thank you so much. We've got a couple of questions for you. The presentation was very nice, but you know we are bedside clinicians, so perhaps there will be some questions on that are more practical.
Good morning. Thank you very much, Dr. Inchespi, for your very nice presentation. Could you comment on the impact of the timing of the intervention compared to the induction of sepsis, how important that is for this particular treatment?
Yeah, that's a very good question. So, yeah, it's going to be very important to combine our approach with the use of biomarkers and, you know, sort of personalized medicine. So we need to know that we will inject our immunoadjuvant therapy at the time when the patients are immunosuppressed. And based on studies that have been performed now for about 10 years, and also based on other tools that we will use to identify the patient, we will likely inject the patient in the second phase, which is around 5 or 6 days post-admission in the ICU. Normally, based on these published studies and what we will test, we will be able to assess the lymphopenia, the expression of HLA-DR and other markers. So we will be very careful and make sure that we inject the product at the time when immunosuppression is established in the patient.
And following up on that, you mentioned potential next steps, but before you may actually want to test this in humans, what would be the next necessary steps to do this in a safe manner?
So you know that. So we have run experiments in naive mice, sepsis mice, a couple of models. We have also some early data in human primates. So the next step for us in the development is to perform, of course, regulatory toxicology studies. So there will be a very careful toxicology studies with a dose increase of the product in primates. This will be performed in primates, and this will assess, you know, the safety of the MVA. So recently there has been an MVA, the same vector that we used in oncology. This is a vector which is very much used in oncology by the company Bavarian Nordic. They've used the IV route in patients with tumors and with very similar dose and hours, and there hasn't been any particular side effect in those patients. So yeah, the next step would clearly be to do a regulatory tox studies before we go to the patient, of course. Yeah.
Okay, thank you very much for your questions. Very exciting stuff, and we look forward to seeing more of your work coming to us. Thank you very much.
Thank you.
Because I think it's time to go to the next presentation. We'd like to invite Dr. Sanchez to talk on the clinical evaluation of a novel continuous absolute and expiratory lung volume monitoring method based on the capnodynamic principle. Let's hear from him.
Hello, my name is Juan Antonio Sánchez Giral from Hospital de la Princesa, Madrid, and I am going to present the result of the study that we have carried out in our intensive care unit. The purpose of this study is to evaluate the ability of the capnodynamic method to continuously monitor change in expiratory lung volume based on CO2 in response to change in PEEP by comparing it with simultaneous change in electric impedance tomography aeration. The capnodynamic method is a new method based on expired CO2 kinetics and the differential fit equation that provides breath-by-breath absolute values of expiratory lung volume and effective pulmonary blood flow. To solve the capnodynamic equation, cyclic change in alveolar CO2 concentration are made. These changes are induced by a modified breathing pattern applied by a servo-E ventilator, consisting of the addition of a short expiratory pause to the last 3 consecutive breaths of a sequential repetitive series of 9 breaths, as you can see in this picture. Intensive care unit patients under passive mechanical ventilation were included. Patients were continuously monitoring with expiratory lung volume based on CO2 and electric impedance tomography. The study protocol consisted in 3 incremental PEEP steps of 5 centimeters of water, starting at 5 centimeters of water or pen if poorly tolerated by the patient. This was followed by a recruitment maneuver and finally the same PEEP step, but now in a decremental order. A total of 96 paired measurements were made. Incremental and decremental values of inspiratory lung volume and electric impedance tomography aeration were significantly correlated by Pearson correlation coefficients. Concordance between method of all paired values was 92%. Concordance was better in the decremental PIP step as compared with the incremental PIP step. Measured absolute inspiratory lung volume at each decremental PIP step were higher than his corresponding incremental PIP step. As a conclusion, capnodynamic inspiratory lung volume based on CO2 correlated well and had a high concordance with electric impedance tomography change in aeration. This is the first clinical method that provides absolute, continuous break-by-break static volume values. If further validated in different intensive care unit population and lung condition, it can become a promising bedside monitoring option. Thank you.
Thank you very much, Dr. Sanchez. Great to have you with us. I hope you're ready to answer some questions.
Juan, that's a very nice study. I really like it. I've got two questions for you. The first one is, are you able to describe, because it's nice that you can have you have the ability to measure the absolute volume, but can you have you tested somehow whether this new tool is also able to discriminate between patients who are recruiters or non-PEEP responders? Have you tried this?
Yes, it's a very good question. Do you hear me? Okay. Yes, it's a very good question because it's something that we can see at the conclusion. We can see that at the down step phase of the study, we can see that the inspiratory lung volume is greater than in the beginning of the study. But due to the low number of patients that we have recruited, is not significant, the result. But it's something that we, if we increase the number of patients that we have in mind to increase the number until 32, it's something that we are going to test. If the patient that has a high inspiratory low volume during the down step phase is correlated with the lung recruitment by the electric impedance tomography. It's something that we have on mind.
Okay, fantastic. Thank you so much. Very quick questions, very briefly. The picture that you showed was very small. So what's in between the capnometer and the computer? Do you need a special device in order to be able to use your method?
Yes, the method right now is in MATLAB in a personal laptop, so we need a specific software connected to the servo E ventilator to detect the change in inspiratory lung volume and to run the algorithm. So the answer is that you need not also to change the respiratory pattern, you also need the software to detect the alveolar CO2. So the answer will be a personal laptop.
Thank you very much. Thank you, Juan. Fantastic presentation. So let's move on. The next one is, and actually the last one is by Dr. Janssen on the systemic inflammatory response induced by lipopolysaccharide administration and the difference between man and woman. So we've got a gender study now.
Hello everybody, my name is Aaron Janssen. I'm a PhD student at the Radboud University Medical Center in Nijmegen, the Netherlands. And both the title as well as the conclusion of my talk is that the systemic inflammatory response induced by LPS administration is more pronounced in women than in men. Okay, so first of all, why are these sex differences important? Well, as we all know, systemic inflammatory syndromes such as sepsis and COVID-19 are highly heterogeneous and can comprise both hyperinflammatory as well as immunosuppressed phenotypes. What we also know is that both incidence as well as outcome statistics are different for men and women. So perhaps a better understanding of the sex-specific differences in the immune response might facilitate more personalized treatment approaches. So what we did is we included 56 male and 54 female healthy volunteers, and we challenged them intravenously with a dose of bacterial lipopolysaccharides to induce a transient systemic inflammatory response. And we challenged them twice, actually. So the first challenge served to study the extent of the primary cytokine response, which resembles more the hyperinflammatory phenotypes. And the second challenge on day 7 served to determine the degree of endotoxin tolerance, which bears many similarities to immunoparalysis. And the degree of endotoxin tolerance can be expressed as the difference in the area under the curve of these two cytokine responses on both days. So first of all, we found that females produce much higher levels of pro-inflammatory cytokines than males, and this is actually true during both challenges, whereas levels of the anti-inflammatory IL-10 were not different between men and women, and also the degree of endotoxin tolerance did not differ between the two sexes. We also explored whether these differences can be caused by hormonal factors. So what we did is we divided the females into 2 groups based on the use of the oral contraceptive pill, or OCP. And what we found was that OCP use was associated with much higher levels of pro-inflammatory cytokines, although females who are not on OCP still produced higher levels than males. And again, the anti-inflammatory IL-10 was not different. We also looked at a couple of clinical parameters. So for instance, the LPS-induced decrease in blood pressure was much more pronounced in females than in males, regardless of OCP use. And also females on OCP reported higher peak symptom score severity, although their fever response was actually less prolonged and less pronounced. So to conclude, females mount a more pronounced pro-inflammatory response to LPS than males, which is reflected in cytokines, symptoms, and hemodynamics. This is probably mediated by sex hormones, so we're still analyzing sex hormone profiles to investigate this further. Thank you very much for your attention, and I'm looking forward to the discussion.
Thank you so much. We've got a couple of questions for you.
Good morning. Congratulations on your work. This is the battle of the sexes that we have here at the last presentation. Now, you mentioned, of course, the potential role of sex hormones in this, but this is, of course, the most obvious thing. Are you considering any other mechanisms that could be behind this?
Well, yeah, obviously. This study was actually a sort of observational study in which we collected many different types of data. So we have, besides from sex hormones, well, of course, we measured cytokines. We also did a lot of ex vivo stimulations. But what we also did is collected a lot of genetic data. So I think another possible explanation might, of course, be that there are genetic differences between men and women, which might also contribute. So yeah, we're definitely looking at different angles. We're not just solely focused on the sex hormones, but I think that was probably the most obvious thing to explore first.
And at this meeting next year, maybe. Now, from another perspective, how does it relate with the clinical data that we have on sepsis and septic shock? Did you see any connections with what we've been studying, what we've been seeing, the clinical data coming from our clinical practice?
Well, yeah, I think the most consistent observations we see both in sepsis as well as now again in COVID-19 is that males are affected more often, but also more severely. So the morbidity and mortality is higher in males. And I think that kind of makes sense when you look at the immune response that we observe in our study, because females mount a much more pronounced inflammatory response. So one of our hypotheses is that maybe due to these differences, females are better able to clear their primary infection, whereas males might have some more trouble with clearing pathogens due to their immune system being a bit less aggressive. So I think it kind of makes sense if you look at the epidemiological data as well.
Okay, thank you very much. More work for you, I would say. So keep us in the loop. Thank you very much for your contribution. I think it's time now to close this session. I would like to thank, first of all, the presenters. We've had different, very diverse areas of research being presented. I have to thank my co-chair, and I think we wish our audience a very nice Congress. Thank you, and bye-bye.
Bye. Bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. good morning. Hello everyone, wherever you are in the world. I am Maurizio Cioconi, President of the Society, together with my friend Eli Azoulay, the President-elect.
Good morning everyone.
How are you, Eli?
Wonderful. I'm very happy to be here this morning again.
Second day of the conference.
Yeah, and a very nice conference yesterday with the release of the Surviving Sepsis Campaign guidelines and all this very well-attended session. So we were very, very happy about it.
Yeah, lots of content, a lot of interactions, thousands of delegates on our platform. So it's great to see you all connected. As we said, we hope to see you face-to-face next year, but it's great to see that the community is together, even in this virtual way. And today, Eli, I'm very excited because this evening at 6:30 Central European Time, for every member, we have our General Assembly, which is an important moment. We get together with the members, but today we are official with the new society, basically, with all the changes that we made over the summer and the elections and so on.
Very important. New faces and new people bringing a new insight to the society, and I think that this is the hope that we have for all of you, is to be part of the society as an active member. You are part of the society and we need you as active members, so today is really a great change, an important time for the society.
Yes, no, it's amazing, but let me spend just a few seconds to thank all the candidates for the recent election, because I would like to remind everyone that we had 33 positions open, and for 33 positions we had 88 candidates, which is really a kind of a record. Basically, 1 every 100 people almost in the society decided to be active and to stand forward, and we have more opportunities and more ways to be involved, even if you didn't make it in this election.
And it's not rare that someone can apply several times to the same position, because as there are many candidates, not everyone can be elected, but everyone will be a certain time, and we are looking forward to it. And thank you for all those who applied and were standing for these nice positions.
Yes, and I really think it's been a year where I really made me proud of the membership. And now members have been supporting the society, really been there to support the society, to bring the contribution in a very difficult year. But I have the feeling we're actually stronger and we are evolving and we're growing with a lot of changes. In the summer we approved the new statutes and the new standard operating procedures. We choose 5 values together. If you remember, the values that we thought are the values of us as officers, but the values of the members of the society. We put that into something easy to remember, which is drive. And I think it's really great to see how everyone embraced that and decided to go on that. But do you remember what drive is?
I think that D must be diversity.
It is. R is respect.
And I think that we should spend time on diversity because, Maurizio, we keep talking and speaking about it all the time. And I just want to say it's not a philosophical or abstract concept. It's something that is very present in all of us. Basically, as people leading the society, we also need to be conscious that we need to be attractive for every member. The best way to be attractive is to have an executive committee and people leading the society that are like the members. And the members are very well balanced in terms of gender, origins, diversity, and many different visible and non-visible things that make that we need to look like you. So it's much beyond something, it's beyond a whole concept of us being very interested in having an executive committee that looks like all of you, which is very important.
It's very important, and I'm actually proud how the executive committee, the council, the leadership embraced this, because let's face it, we had a problem. We were not diverse enough in the leadership positions, but it is the leaders themselves that decided to make some important changes. Like, for instance, in the executive committee now, the mandates are 2 years only, and you can only stand for 2 mandates, and then basically you have to give space to other people. And we all decided it was the right thing to do, to give more opportunities to others.
So more people will be at a position to lead the society, and many of you will be able to replace us, which is a hope that we have, is that to be replaced in the future and have people working for the good of the society. So we need you basically.
And if you come to the General Assembly today, you will see the new faces of everyone involved in the election, the people that have been elected. You will see really how the society is changing, how the executive committee will look like, for instance, next year. We're very proud of this because it is a change that came from the bottom and towards the top, which I think is always the best way to do that. But diversity is not the only value. We said before, respect, inclusiveness, vision, excellence. This is what we thought has to guide our actions now. So respect, a new thing that we've done this year, we put a code of conduct in the society. We realized we didn't have that, and I think it's something, again, that you have voted, you have approved to have there, and we actually think it needs to be there.
Absolutely. I think that respect is a basic principle that makes that people who have another job, who are physicians, nurses, and other allied professionals in their countries, in their departments, mostly critical care, they come to the society to bring and to make the society really great. So this should be in an ambience with a climate that is really respecting each other, is also having a good ambience and working together and thinking on the society. So the society is at the center, and we, the officers, we want to make it bigger.
It is like that, and inclusiveness sometimes people think, what is different from diversity? It is different in the sense that you can still be diverse, but maybe not as inclusive as you should be. And so in that I'm very proud that now we have part of the structure of the society, for instance, the Global Intensive Care Group, which is a group that is there to really to embrace the global intensive care community, to help having more representations from low and middle income countries. I keep reminding everyone, it's not about teaching to low and middle income countries, it's about working together. We will learn so much from each other. The pandemic has been unique in this sense, to see how much we've learned from each other. And you know, that's just one of the examples, but inclusiveness is of course a very important thing of what we do.
A very important message. We are the European Society of Intensive Care Medicine, but we are a global society. We have friends, colleagues, and teachers, and we can see that the speakers come from every country. We learn a lot from every country, and I think that this global vision makes us really in another vision of critical care. This is true for every position in the society, but also for the journals and for all the things that are surrounding the society.
And you mentioned vision, which is exactly the V, and again, we spend a lot of time. Sometimes you think you have so many ideas, but you need to bring everything into a key phrase, otherwise you don't have a clear vision. And our vision is exactly that. We are a European Society of Intensive Care, but we are a global intensive care society that want to give equal opportunities to everyone working in intensive care to improve the care of patients and family at the bedside, with research and education as leading lights. I think this is really our vision, and I think with these values we can be excellent.
And this is true, and this is also your vision. For example, yesterday was the first day of the conference, and Mauricio and myself received hundreds of messages, text messages, emails from you, saying and providing feedback on all the activities, and we are nourished and we are fed by this vision that also inspires us a lot. So please keep on encouraging us and providing us feedback, because this really is our vision for you, so it's your vision.
Yeah, and ultimately the reason why we do this job and we love this job is because we want to provide excellent care at the bedsides for patients and families, and to create a good working environment for our teams as well. I think that's also very important, Ellie.
This is very important. For the patient and families, they are experts, but I think that every ICU specialist, every doctor, every nurse, every allied professional in the ICU is an expert, because you are talking to patients, you are talking to family members, we are learning from each other, we are inspired by each other, and then we are taking this, and I remember during the opening ceremony, the 3 testimonies that have been provided by the patients and the family members were really qualitative and brought a lot of ideas to develop into observational studies and hopefully trials. As you all know, and I know that you have, most of you have completed the survey on ESICM Family 1. Otherwise, you can go on the website and complete the survey for those who didn't have time to do it.
So we talk a lot about this. We like the idea of being global, but we also know that we are a European Society of Intensive Care Medicine, so there are some specific topics related to Europe, and we have some challenges in Europe. I mean, you and I were friends. We've been working together for many years, but we would find it a little difficult sometimes maybe to work in each other units, depending on the regulations that are around there. So the free movement of intensivists is something that unfortunately is not sorted yet at European level.
Not yet, but people are working on it, and I know someone, Professor Maurizio Cecconi, who is the president of the European Society, who is pushing with this catchword that is together we are intensive care. Whatever is our base specialty, of course, if we have the competencies, if we are trained appropriately, we are able to be an ICU specialist and to work in other European countries. This is very important. This is not a way to pick specialists in one country and bring them to another country to be better paid or to have another quality of life. It's not about that. I think that most people want to move, but they also want to live in their countries. It's just about solidarity. It's just about being an entire community and being able to cross the borders and help each other. The borders can be at 20 kilometers, they can be at 1,000 kilometers, but still, I would like to go to the medical school in Italy, to have a training in France, and then maybe go to Germany for 2-3 years and go back to one of those countries. This free movement is about freedom, but it is also serving the patients and the entire critical care specialty.
And maybe we need to clarify some confusions, because when we speak about the free movement, people think, oh, maybe they want to do something completely different from what it is now. Of course not. We have so much richness and diversity in the way you become an intensivist in Europe now. Sometimes I'm an anesthesiologist and I'm trained in anesthesia and intensive care. You have a different background. There are people with primary specialties. We don't think there is a ranking here. As long as the competencies are achieved in an adequate amount of time, you think you should be an intensivist. We don't have this in Europe at the moment. The professional qualification does not exist. It's easier sometimes to move a patient country to country than actually to see intensivists spending a period in one intensive care unit. This is not acceptable, and that's where we're working on, but I'm very pleased to see that this conversation now is occurring more and more at European level. It's important for citizens, ultimately. It's not just for us.
And I believe that it's time maybe to explain what is the Annex 5. Everyone hears about it, but maybe it's time to clarify what is the Annex 5 exactly.
The Annex 5 is something that sounds very complex. It's one of the annexes in the European Commission. It just specifies what a profession is. It doesn't mean that it needs to be a primary specialty for what concerns doctors. It just says that it is a specialty. So that could be a specialty that is a supra-specialty, 2 years on top of something else, so within your training, or a primary specialty. And we think that this framework of the recognition of competencies between different countries, as long as you have these competencies and you train for it, it's something that will help us really to work and to have this free movement. So we need to be in the annex.
And in this Annex 5, we are very clearly not making the promotion of any base specialty and not making the promotion of the primary specialty. It's just about, for every people who are ICU specialists, whatever is their background, to have the competencies and to be able to reach a certain level of what we hope will be the level of ICU specialists throughout Europe, so that the free movement will provide the same physicians with the same competencies wherever inside the European community.
Yeah, and I think, Ellie, this is something that you and I now, we had this career for a number of years, but especially for the youngest physicians, the youngest people in our teams, we really need to find a solution for this, especially now that we had 2 years in which no one could travel, no one could meet and create these opportunities. We need to have a much better way to facilitate the free movement of intensivists in Europe.
Everywhere in Europe. You wrote an editorial about it, published in the SICM journal Intensive Care Medicine, and I believe that people listening to us could go to this editorial that was published in 2021 and would be a very nice opportunity for you not only to be read but also to be looked at, because there are graphic elements that are providing you with very simple and a very quick way to understand to where we want to go.
And I think you were an author as well, and you are the next president, and we also had Joseph Keseshoglu, who is the past president. He showed that there is a clear vision about this in the society. society, and it's open access, so everyone can access this editorial, and basically that's the vision of the European Society of Intensive Care for the free movement of intensivists.
So for 2021, we are online, and I thank you all for this wonderful success. And for 2022, it seems that we will have opportunities to see each other face to face, maybe different times.
Right, we will have a lot of face-to-face events in 2022. Importantly, everything that we do now is with these 5 values in DRIVE: diversity, respect, inclusiveness, vision, excellence. We want to be inclusive. It means that if you cannot travel due to some restrictions, don't worry. We will carry on with virtual, we will carry on with interactivity, even without face-to-face meetings, but face-to-face meetings will be there. So we look forward to meet you in person, maybe for a coffee this time as well.
Have a wonderful 2021, Lives 2021.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
A very big welcome to all of you, where we will have a roundtable on drug therapy in COVID-19, and I'm sitting here with the co-moderator and my friend Professor Nicole Juffermans. And we will have a very open discussion with 4 experts in this field. Drug therapy remains a cornerstone of the possibilities that we have as a treatment in the intensive care, and that is true for COVID-19. And I'm very, very honored and glad to welcome our 4 distinguished speakers for this roundtable. Leni Derde, who is from Utrecht, the Netherlands. Good morning. Jilali Anand from, if I may still say, Paris, Manu Shankar Hari from London, and Geeta Mehta from Toronto. So we have a lot of continents are represented. Well, we would just like to have a very open discussion, and we are very eager to know your opinion about what is the current evidence that we have, and we will mainly focus, of course, on a treatment on the intensive care, perhaps a little bit also about just before or just after the intensive care, but mainly focus on the intensive care patients. So if I may start with Leni, what do you consider as what is now beyond any doubt that we should do as a drug treatment in COVID-19 in the intensive care?
Thanks, Armand. So I think the evidence for the use of corticosteroids in the intensive care is overwhelming and of high quality. And a second drug, I think we've proven in pragmatic trials to work, is the IL-6 receptor antagonists, tocilizumab and sarilumab. I do think for those 2 in the intensive care unit, there's great evidence.
Together, Leni, if I may already interrupt you a little bit.
Yeah, that's actually a very good point, and I think Manu will probably have something to say about that. So that is something that we thought may explain the difference between the first early, mostly pharma-sponsored studies on IL-6 receptor antagonists that did not use corticosteroids as a co-intervention, and the later studies, Recovery and REMAP-CAP, showing an effect of these drugs in the presence of corticosteroids. And we've just in July published with the WHO REACT group a meta-analysis, prospective meta-analysis of about 27 trials and over 10,000 patients that does suggest that the co-use of corticosteroids matters. But I'll leave it to Manu to reflect on that further.
Well, go ahead, Manu.
Thanks, Lenny. So yeah, as you highlight, so the IL-6 meta-analysis had a pre-specified subgroup of corticosteroids, yes, no, and the odds ratio for those patients who got corticosteroids was around 0.71, with a confidence interval that was less than 1, 0.63 to 0.8, and those who did not get corticosteroids had an odds ratio of 0.96, for IL-6 receptor antagonists with a confidence interval straddling 1 from 0.8 to 1.2. And this heterogeneity in treatment effect by subgroup makes us feel that the effect of IL-6 antagonists will be enhanced by concomitant corticosteroid therapy.
So what about the dose, Gilali? Would you agree with this dose of dexamethasone 6 milligram? Is that the right dose to give?
Yeah, I think that no doubt that corticosteroids for patients with COVID-19 who require some sort of respiratory support, not all patients, may actually benefit from corticosteroids. But when you have said this, the question is, okay, how to do it in practice at the bedside? Because, you know, corticosteroids, number of molecules, which dose, how long, and so on. So I think in a pragmatic way and in an evidence-based way, today, one can say that in COVID-19, corticosteroid has a class effect. So use the corticosteroid you are familiar with. If you're familiar with Dex, use Dex. If you're familiar with methylprednisolone, use methylprednisolone. If it's with hydrocortisone, use hydrocortisone. Regarding the dose, I think the evidence so far suggests that you should not use more than 6 milligrams per day of Dex, which is 30 milligrams of methylprednisolone, 150 milligrams of hydrocortisone. The duration of treatment, and we see in practice things that are, to me, malpractices. We see patients remaining a while receiving corticosteroids just because it's not improving. This is not evidence-based. What the current data say is the patient should be treated for no less than 5 days, no more than 10 days. And so finally, if you follow these strict guidelines, then the evidence says that every 17 patients treated, you will save 1 additional life. If you do not follow this very strict pathway, then there is some evidence suggesting that the number needed to harm a patient is 25. That means any 25 patients you're treating outside strict guidelines, you may harm 1 more patient. So there are remaining questions now. What is the room for rescue therapy? What is the combination with other immunosuppressive drugs? And we see, as mentioned by Lenny and Mani, that there are evidence for synergistic effects with the anti-IL-6 receptor antagonist. But there is no enough data for the other immunosuppressive agents, like the JAK inhibitors, for example, and how they interact with corticosteroids. So you might be more careful by combining corticosteroids with other immunosuppressive agents than IL-6 receptor antagonists. And finally, we are lacking data on the long-term effect of corticosteroids in these patients, and in particular the safety when in the long term. So, and my final word on that topic is that now what we need to figure out how to treat individuals. So we need to go deeper in the mechanism of action of corticosteroids and to personalize these treatments to the patients.
If I may add one thing before Nicole takes over. You said this was your final word on that subject that I do not completely believe, Gilali, but you know, tomorrow Anders Perner is going to present the results of the study he performed comparing 6 and 12 milligrams of dexamethasone, and I'm not going to tell the study that he has done so very well, but the study results give us perhaps some doubt about the ideal dose of 6 milligrams of dexamethasone, and that it should be perhaps a little bit higher. What is your opinion as a panel of this?
Yeah, my opinion is because the result from this study has been publicly released on the preprint server. So we know that 12 milligrams of DEX did not improve statistically the outcome, the patient-centered outcome in that trial. And also, we know from a French trial that has compared 6 to 20 milligrams of DEX, that there was also no significant difference in terms of patient-centered outcome. So again, the evidence today says that 6 milligrams of DEX is the right dose to use in practice.
So you touched upon a lot of subjects, Dr. Enane, but before we move on to the combination of drugs, just a final word perhaps or comment on the use of steroids. What about, and I'm eager also to hear Dr. Sangeeta Mehta on this one. I guess we all experience specific patients which have refractory ARDS even after having received 10 days of steroids for 6 or 12 milligrams. This we need to be decided. But unresolved ARDS, what will be the place of a repeat dose perhaps in those selected group of patients? Any idea of the panels on this one? Dr. Mehta, perhaps to start?
Sure, thank you. I agree with everything my co-panelists have said. Yeah, so the individual patient, I think there's two scenarios here. One is the patient who has improved very quickly. Does that patient actually need to continue dexamethasone for 10 days? And the true compliers with evidence will continue for 10 days, whereas we actually had stopped steroids earlier if the patient improved dramatically. And I do worry, as Jalali said, about the long-term effects of these high-dose steroids. And then in the non-resolving ARDS patient, who I think may be similar to our non-COVID, non-resolving ARDS, and we know after 10 days that many trials have shown that steroids are ineffective in improving their lung function. And at that point, if they're not improving after 10 days, I can't say we've never continued steroids beyond that, but we look for other explanations, other reasons for their non-resolutions, such as hospital-acquired infection, ventilator-associated pneumonia. We look quite diligently for that. And we do consider repeating steroids or continuing steroids beyond 10 days, but it hasn't been a rule for us. We also look at imaging to see whether the patient has developed fibrotic lung disease.
Thanks for that. So, as already alluded to, there seems to be a synergy between steroids and anti-IL-6 antagonists. And this really ponders the question of how should we interpret trials investigating interventions in patients having received steroids but not having received tocilizumab. And there have been a number of those, and Dr. Anand already touched upon this, such as the JAK inhibitor. The trial was published in the Lancet 10th of September. And these patients have received steroid, or the majority of them, but no anti-IL-6 antagonist. So how should we interpret the results of that? Open for the whole panel.
Yeah, so Nicole, if I can maybe get the discussion started, and I hope the others will jump in. So I think that was a very interesting study. So baricitinib is the JAK inhibitor you're referring to. So I think we should just try and, kind of as objectively as we can interpret the evidence in front of us. If you look at that paper, I think it's a well-designed trial, and the effect seems real. It's actually kind of about the same size as the effect of IL-6 receptor antagonists. So what you wonder is it an alternative? Would baricitinib on top of steroids work as good as tocilizumab or sarilumab on top of steroids? Would it work better, or would the IL-6 receptor antagonists work better? I don't think we have an answer to that yet. It would be great if we could compare them head to head, but I think we also have to kind of view the broad perspective of the most important questions. And you could say, so Gita just referred to, patients not improving and wanting to have a drug that can help improve their outcomes. I think that's very important. At some stage, I think we'd like to compare baricitinib and IL-6 receptor antagonists. Currently, the recovery trial is still recruiting patients to baricitinib. I think it would be very insightful to see those data. And then I think we can interpret that field a little bit better and see how best to move forward while we also investigate other things. But yeah, it's a very interesting trial.
Any input from others?
Yeah. Go on, Giselle.
No, go ahead, Mike. Go ahead.
No, go.
No, I would say, I think, for sure, it would be nice to get a platform trial engaging in head-to-head comparison of these two molecules. But meanwhile, the scientific community might also consider putting together the databases and doing network meta-analysis with indirect comparison of drugs, and that will actually provide some useful information awaiting for a head-to-head comparison of these drugs. And I think that might be a way forward in the very short term.
Manu.
Yeah, I think just to add to Gisele's point, completely agree. The other thing to probably keep in mind is when you add these drugs as immunosuppressants, you're going to have to expect an increase in the risk of adverse events. You can't have the current kind of hypothesis from which when you design a trial, you expect the adverse events to be constant across the baseline risk and the treatment effect to get increased with increasing baseline risk. The adverse event profile of multiple interventions will change when you combine many interventions. So I think network meta-analysis is one way of addressing that question if the data is granular enough. The other way is to think about it, as Lenny highlighted, the availability of these drugs are not uniform, globally available, so you just need to figure out whether baricitinib will be a good alternative to more expensive and less commonly available drugs like Toci and Sari.
If I could say something, the idea of a network meta-analysis could be very valuable. But I also wanted to emphasize that because the amount of literature coming out is so overwhelming for me, as more so for the average clinician, there are a few groups around the world that are doing living meta-analyses, including a UK group, the ANZIX group, and the McMaster group. And those resources are extremely useful, even for me. The question is, replacing Toci with another drug that has another mechanism of action needs to be compared head to head, but notwithstanding the potential for combined immunocompromise with multiple drugs, a JK inhibitor as well as an anti-IL-6 inhibitor may also be effective. So combinations, given they have different mechanisms of action, combinations of these drugs may actually be very effective, being very cognizant of the combined immunosuppression and potentially long-term effects.
Something that has not been mentioned in the therapy, because in drug therapy, in my mind, what is important is, of course, the choice of the drug, the dose, but something that we have not discussed is the timing of giving the drug. Perhaps the panel can say something about what we know about the timing, both based on the current evidence we have from studies, but also looking at it from the perspective of pathophysiology, how it works. Could you please comment on that? Manu?
Well, I may start with the issue of corticosteroids, I guess, because it might be the most easy to deal with. So actually, we had fair data from the recovery trial suggesting that not the sooner, but you may get more benefit from corticosteroids if you get the patients receiving the drug, let's say within the first 10 days following the onset of the respiratory symptoms. Beyond the data are lacking to make sure that the balance of benefit to risk for corticosteroids is still sufficient for routine practice.
Others to comment on this?
Yeah, I could come in with the IL-6 receptor antagonist as an example. So in the prospective meta-analysis, what we had was different subgroups of patients in terms of their respiratory support. So those patients on oxygen, flow rate less than 15 liters per minute, those requiring high flow nasal cannula or NIV, those requiring invasive mechanical ventilation. The treatment effect seems to be higher if you are on a lesser respiratory support. So in other words, if you have patients on non-invasive ventilation, they progress less to invasive mechanical ventilation if you give IL-6 receptor antagonist. If you're on high flow nasal cannula or oxygen less than 15 liters, you progress less to NIV. So the idea of giving early probably matters there too. The other drug, perhaps I'll just say, and then I'll hand over to my other co-panelists, would be an antiviral drug here would be a good example to think about. People have talked about timing of interventions with antivirals. Patients who are critically ill, which is the population that we look after, perhaps the antiviral is not going to kind of provide significant benefit compared to an antiviral given earlier on in the hospitalization or in the pre-admission setting, like outpatient setting. So, in fact, the REMAP-CAP trial, we showed that if you were to give an antiviral drug whilst in ICU, you may be producing harm. So, yeah, with that, I'll hand over to my colleague.
Leni, can you comment on that, or Dita?
Oh, yes, sure. 2 points. One is in terms of the timing of the dexamethasone and tocilizumab, which have the strongest evidence base so far, that I just want to emphasize that the indication is for either suspected or confirmed COVID-19, so not to delay starting. And Jalali said within the first 10 days, but really the literature suggests as early as possible, starting these drugs quickly on the floor, even before they come to the ICU if they meet the criteria for high flow nasal oxygen or NIV. And then 2 is what Manu brought up, and maybe we should talk about what not to give, because there's a lot of quack medicine there, a lot of misinformation. We have patients coming in and their family members demanding certain treatments like hydroxychloroquine.
Well, please take it away, this subject. What should we not give in ICU?
So Nicole, if I can pick the ball up from where Gita ended, I fully agree. I think the only thing to say about corticosteroids before we move on to what not to give is you shouldn't give it too early. I think that was very elegantly shown in the recovery trial that those patients not yet on oxygen but hospitalized, they were actually worse off. And what you could see is a disadvantage seemed to be happening after about 7 to 10 days, which is, and you know, this is interpretation. This is not what the trial was looking at or powered for, but you know, it suggests that those patients suffer maybe from like secondary infections or something, which could, you know, make them worse off after a week to 10 days. And they didn't have enough inflammation yet to benefit from that treatment. But again, that's pure speculation, and we haven't investigated that in depth. But there's such a thing as giving it too early. In terms of things that we should not give, I think it is pretty clear for the ICU population that remdesivir hydroxychloroquine, and lopinavir-ritonavir, 3 antiviral agents that have been investigated for COVID-19, do not benefit patients, and actually hydroxychloroquine and lopinavir-ritonavir are likely harmful to patients. I think that's been proven in multiple studies. The other thing that we investigated in REMAP-CAP is actually not aimed at the virus itself, but one of the common complications, which is thrombosis. I think we all recognize that. And what we found, and this is very, very interesting, is that in the critically ill population, giving patients therapeutic anticoagulation does not improve their outcome, while the less severely ill, the non-critically ill patients, did seem to benefit. And obviously you have to take into account the in and exclusion criteria of the trial. It's less easy than an antiviral, but I think those are the most important things not to do.
Yeah, if I may continue at that topic, I would advise people refraining for using in practice anything that has been shown in a RCT to be effective. We're no more in March 2020. You know, in March 2020, we all did what we could do for our patients, including use in emergency situation of drugs that were repositioned from their marketing authorization. That was the past. Now there is no more room for such behavior. Okay, so I think anything that has not been proven to be safe and effective for patients should not be treated. For example, fibrinolysis, okay? That might be dangerous for your patients, and there are ongoing trials, but so far no proof to use them. The same for the complement inhibitors. And one can list a have a long list of drugs to avoid. I think the best way to make it simple is if there is no RCT showing safety and efficacy, I will not use it unless in a context of a clinical trial.
Can I come back before we move on for the other issues in the treatment of COVID-19? Would it be thinkable that an antiviral drug would play a role in the ICU treatment of patients? Isn't it by definition that it's always too late to start this antiviral drug? As you probably are aware of, there is a new press release from a pharmaceutical company about molnupiravir, that it showed very promising results. But this, of course, is not the ICU population, but an outpatient population. Could you comment on this from a perspective of pathophysiology and, well, extrapolating a little bit the data that we have from the trials? Is it a way that we should continue to go to look for an antiviral to act?
So yeah, perhaps I'll start the discussion purely from a biology point of view, and then co-panelists can pick it up. So we have done, as part of the REMAP-CAP trial, we did viral load in patients receiving convalescent plasma, and we've done that at admission up to 28 days. The viral load is spectacularly high in patients who are critically ill. So that is one reason to still think about the role of antivirals in that population. The second reason is we did measure viral anemia in blood, and it's published again in Nature Med, where we show that actually nearly 20% of patients have got viral anemia detectable in blood. And there is a relationship between presence of viral anemia and more severe disease. The reason why I'm calling it viral anemia is because we haven't cultured live virus in blood, we are just seeing RNA. And the third reason why I think it's still worthwhile pursuing this antiviral hypothesis, provided we can find the right antiviral, is that the part of what we are seeing as the pathobiology of disease is related to the presence of virus, either in the tissues like lung, where there is a lung macrophage viral lymphocyte circuit that perpetuate lung inflammation, causing lung fibrosis longer term, and the presence of virus in itself will enhance host immune response. So there is value in pursuing it, and I'm not sure what is the right time at which we say, okay, the antiviral probably at this time in the critical illness is probably not a great idea. And that debate needs to be kind of figured out scientifically, but there is value in pursuing it.
Which antiviral is a good candidate as far as you're concerned for looking at that aspect with the data that we have today?
Pass, I don't know the answer.
Well, that is also an important answer. Anyone else on this?
Armand, you also asked about molnupiravir, and I think it's important that we at least briefly discuss it, because there was this recent press release that was very enthusiastic, and I do think it's important to say that indeed that was in outpatients. They also had a trial in inpatients that was actually stopped for futility. So molnupiravir is an antiviral agent. It actually also has some anti-influenza activity, and you give it for 5 days. The press release is about interim results of this outpatient trial, and it does show a strong effect, which is consistent with their phase 2 data, actually. What you have to realize is that these were, so first of all, outpatients, but also sick for less than 5 days, less or equal to 5 days, I think, and falling into a high-risk category. So I think, it's interesting to follow it, and I agree with Manu that there's still a rationale for pursuing potent antivirals in the ICU, but molnupiravir, I think we're going to follow the developments a little bit before we start giving it in ICU.
Gita?
Yeah, I'd like to echo what Lenny said, and just caution around making any conclusions about preprints and very small studies. A 200-patient study, outpatients, where the outcome, phase 2A, where the outcome was viral clearance and no clinical effect at all. And Jalali made the point that we need to rely on RCT evidence to change our management. However, we all have experience, for example, with PROWS, activated protein C, how one large RCT changed our management very quickly and subsequently was not found to be effective. So not just one RCT, but we need multiple RCT evidence for these new drugs that have potentially very high toxicity.
Did we sufficiently mention the monoclonal antibodies as a therapeutic tool in the intensive care?
I may start on this question. I would say I can at least see one group of patients in the ICU that might deserve being treated with these monoclonal antibodies, neutralizing antibodies, and paradoxically is going to be non-COVID-19 patients, highly immunosuppressed. And we know that these patients, although being vaccinated, remain at high risk of getting severe COVID-19, and at least in France, but I think it's true also in other countries. There is now proposal for prophylaxis in this very selected subgroup of patients at high risk, deeply immunosuppressed, and when they came in the ICU, one might consider this treatment approach.
Nicole?
Might be a little bit provocative for Marco-Panalis, but we'll see.
We're hearing you that we should follow results of randomized controlled trials, but I would like to take the discussion a little bit away from RCTs and meta-analysis into the real world, because actually we are treating real-life patients, and a significant subset of these patients have not been included in RCTs and hence not in meta-analysis. And these, of course, pertain to the immunocompromised patients. So how to treat those patients? What does the panel think about administering tocilizumab or any other intervention to patients with immunosuppression? For example, cancer patients, HIV patients, whatnot.
So I'll leave it to the others to maybe give a more mechanistic answer, but from the trialist perspective. So both in recovery and REMAP-CAP, these trials have tried to be pragmatic and have made sure that they exclude as little patients as possible. So to make it a generalizable intervention across patient subgroups and also across the globe, depending on availability, unfortunately. So I know for a fact that in REMAP-CAP we did not exclude, for instance, cancer patients, and we only had very specific exclusion criteria that you do need to fulfill the safety regulations of a trial. And I fully agree with you, Nicole, that RCTs are not the only important thing. I mean, how could we even do RCTs if we didn't have, pathophysiological work, figuring out, for instance, the genome of disease, confirmation of the disease and testing, pathophysiological pathways, and then identifying promising drugs in preclinical work. That all needs to be done. Also, observational studies, especially in the beginning of the pandemic, have been very, very important, to identify the most promising drugs that we should test in clinical trials. So I fully agree that we need a whole research portfolio and not just one type of study.
Other opinions about combined interventions? We've talked about the balance of immune suppression and the risk of infections. What about these immunocompromised patients? How is the balance there?
So, Nicole, if I can come in. So, first example I probably want to highlight is our convalescent plasma trial that got published in JAMA yesterday. We had a subset of patients that were immunosuppressed as per the Apache 2 definition. And the posterior probability of benefit with convalescent plasma therapy was around 89%. In other words, you could essentially follow the thought that Dijali started, which is that actually immunosuppressed patients may need things that we wouldn't normally consider as part of interventions, and convalescent plasma maybe, or a monoclonal antibody may be another one. The second point about immunosuppression is that we lump them all together into one kind of group. The immunosuppression partly depends on what kind of pathology they have or what interventions they get. For example, if you have a transplant-related immunosuppression, that's a particular set of drugs that you give that target the adaptive immune system more than anything else, as an example. And some of the immunosuppressions that we give may actually not be harmful. We don't know, but I think biologically it is plausible that they don't harm them that much. And the third, probably relevant point here is if you have somebody with immunosuppression, what you're not treating is the immunosuppressed state. What you're treating is the illness state that they've come in with. And if their illness biology resembles that of a COVID-19 illness, in those who don't have immunosuppression, what you would do is what you should do, at least at least initially. Just one kind of declaration of interest before I say this: I am an investigator in the recombinant IL-7 trial in COVID-19 in the UK, which is contrary to what we all have been talking about up until now, which is to suppress the immune system, is what we are doing. With recombinant IL-7, you essentially stimulate the T cells. You activate the T cells and reverse the T cell exhaustion. And we have not seen spectacular adverse events with activating the T cells in patients with COVID-19. So in summary, I think immunosuppression is such a broad term that it needs a bit more nuance. And I think what we know currently as biology is what we should treat, and then think about the immunosuppression as a group that we need to study further. Thanks.
Yes, fully agree with Manu, and to continue on his point, I think we should be careful by using the broad term immunosuppressed patient. A patient with a past history of cancer, even so, still continuing to receiving some sort of chronic immunosuppressive drugs has nothing to do with an acute transplantation, for example, or a patient with acute leukemia, for example. So while the former, I guess, would be in the context of COVID-19 or sepsis in general, might be, let's say, treated the same way than than the non-immunosuppressed patients. Those who are deeply immunosuppressed or have some complex sort of immunosuppression, these patients should be referred in highly trained centers, in centers where the immunomonitoring could be at work on a routine practice, because there is a need for fine-tuning the treatment in these patients. And I guess there is no simple answer. I would say my inclination would be to say, well, for even chronically immunosuppressed patients stabilized on his underlying disease could be managed almost like any other patient. However, the patient with unstable immune states, acutely transplant patients, acute leukemia, these patients should be referred in specific, highly trained center to benefit from immunomonitoring to guide the appropriate treatment.
Gita, go ahead.
Go ahead.
Thank you. I agree with everything that my co-panelists have said, and also wanted to make the point that we treat bone marrow transplants and recipients of CAR T or personalized T-cell therapy in our ICU. And I think an important point is that these patients are probably one of the first group that were actually treated with tocilizumab for cytokine release syndrome. So we had a lot of experience with TOCI in that population, and they tend to receive big doses of steroids as well. So in terms of toxicity of those drugs, we actually have good evidence that that they are safe in that population.
Perhaps a final question related to a specific subset of patients with COVID who have not mounted an antibody response to the SARS-CoV-2 virus. Should we consider this as a specific population? I'm of course referring to the recovery trial. So perhaps Manu as first.
Yeah, so thanks, Nicole. So antibody response to a virus takes somewhere between 10 and 14 days, and that antibody response gets refined over time and peaks at around 3 months and then plateaus off by 90 days. And the antibody positive population represents roughly 70 to 80% in most of the clinical trials that people have published up until now. If you are antibody negative, there is value in thinking about an intervention like a monoclonal antibody, which is what recovery did and showed benefit in that stratum of patients. So as the illness progresses, the chance of antibodies being negative is lower. The challenge here is not to say that those who are antibody positive have all got high quality neutralizing antibodies. That's a completely different kind of biological scenario. You can have antibody positive without significant neutralizing ability because antibody maturation takes time. Thanks.
Any other comments? Perhaps about the place of Regenkov in these patients? As the recovery trial showed a benefit of Regenkov in those not having an antibody response versus those that did mount an antibody response.
Yeah, so Nicole, I do think that I fully agree with what Manu has said, and I think we have to recognize that our patient population is changing, right? So from kind of all comers at the beginning of the pandemic, I think it will be the same across the globe. That in ICU, what we see is two types of patients: those with an insufficient or absent antibody response because of underlying disease or medication that they use, the combination, or people who've refused vaccination. And I think the treatment with things like convalescent plasma and antibodies is very, very interesting, but it's also not just a drug. So I am very, very interested to see how this all develops in kind of the global situation where we may have other variants of concern. We don't know a lot yet about
how these viruses develop in people, for instance, who do not clear the virus. So if you have a long, I don't know what to call it, Manu, but RNA viremia, or you don't clear the virus, that host, that immune suppressed host that doesn't clear the virus, is like could be like a vessel for occurring variants of concern. And I think these things are things we really need to learn about now, because it's becoming very, very important. And it just I think my main point is antibodies and convalescent plasma is not just a drug that we give like steroids. There's really a lot of thinking attached to how we will approach that and what will happen.
Thanks for that, Lenny. I think it's time to wrap up this panel discussion. I think we've discussed a lot of things in this dynamic and hyper-fast changing environment of the COVID treatment. And I think the panel clearly displayed caution against the use of interventions that have not shown benefit in RCTs, as they actually may also confer harm. And another thing that you said is that we should combine the data in meta-analysis and improve our head-to-head comparisons to further improve our abilities to treat COVID in the ICU. I want to thank you for your experience and your expert from all over the place in the world that you are living, and your willingness to contribute your expertise to the listeners in the world. Thanks a lot, and also on behalf of my co-chair, Armand Geerbes, I learned a lot from you, and see you again. Goodbye.
Goodbye.
Thank you. Bye-bye.
Bye-bye.
Thanks.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care for you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure control, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure, that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that of course she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed, that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie. Good morning, Sophie. Hello. How are you? Well, now we'll do the round all together, in which we discuss your improvement and the goals for today. Okay? All right.
Good morning. So, Massimiliano, what can you tell me about Sophie?
Well, Sophie has been with us for 3 days now, and she has been here for a septic shock. I think her condition is generally improving. Her drug levels are going down, and also her organ function is improving.
How about the kidney?
The kidney are also going better, and she is able to have a good urinary output on herself. I think also we are on the 3rd day of antibiotic therapy, and the condition is generally improving.
Okay, and the antibiotics are correct?
Yes, we have identified one bacterium on the blood, and the antibiotic therapy is targeted on that.
Oh, perfect. Alessandro, anything from your side?
Well, during the night with a very, very light sedation, she slept well. She's comfortable. Now, no pain, actually, and a good bowel partner now.
Okay, perfect. So I would say we try to switch off the medication today.
Completely? Okay.
Yeah. And then also later today, we will try if we can get her off the breathing machine and put the tube out. And
Wonderful.
before that, perhaps, Victoria, can we try to sit at the edge of the bed?
Yes, I think we can try. Yesterday she was able to move arms and legs by herself, so why not?
Okay. It will be a little bit tough for you, but I think it's important. So the physiotherapy will help you to sit at the edge of the bed, and then we will see, yeah? And later on, we will try to get the tube out as well. We have no nutrition yet, but I think that's fine since we are improving anyway, and then perhaps we can try after the tube is out to start with normal food. I read something about family issues.
Yes, she had a complicated family situation, so I think it could useful call the social assistance for the roundtable. Yeah.
Okay, Massimiliano, you will handle that?
Yeah, I will call the social assistant today and see what we can do on that.
Okay.
Okay, perfect. This was the very important interprofessional ward round. There, we discuss important information between the healthcare professionals of the ICU team. Furthermore, we discuss the goals for the patient of the day.
Communication with caregivers is one of the most highly valued aspects of care. Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow. Research has shown that families get frustrated or confused when clinicians use medical terminology or abbreviation without explaining them. Also, they get confused when they receive information from too many different clinicians. So don't hesitate as a family member to ask questions, to ask the nurse or the doctor to repeat the information, and more generally, don't hesitate to ask for a meeting with the ICU team.
Hello, Sophie. I'm your physiotherapist. Today, we're gonna try to put your legs out of the bed and to stay sit. We're gonna do that together, me and your nurse, okay? Let's try. Okay.
So, we check the length of the tube. Please check the length of the lines.
Everything's okay?
Okay.
Okay.
Well,
so
together.
We can start. Come here with your legs. Okay.
Oh, good.
Sounds good. Okay. Okay. How are you, Sophie? Is it comfortable for you? Okay. Let's breathe normally.
Perfect.
Okay.
Pain? Okay. Small breath? Okay.
This step is very important for the weaning of the tube, okay? Okay.
This collaboration between the nurse and the physiotherapist is a key feature for the best outcomes of the patient. And together we get off of the bed and sit Sofia on the bed.
Hi, Alessandro. How was your shift?
Hi. Hello, Velia. Well, Sophie, all right.
She's awake today.
Yeah, she is. Well, morning shift was very good. We decreased all artificial supported, and now she goes very better. The goal is to remove the tube, so stop the ventilation by this evening.
Oh, nice.
Yeah.
Were you able to have a physiotherapy session?
Yes, this morning we put the leg outside the bed and she was good.
Okay.
Is it?
Perfect. So, Sophie, I'm going to take care of you for the next few hours and we are going to remove the tube. Are you happy? So you are going to be able to speak again and we can hear your voice again.
Okay.
Perfect.
So, see you tomorrow.
See you. You're free to go, Alessandro.
Bye.
Bye.
Sophia, we're going to take the tube out now. Just breathe normally. It can be a little bit uncomfortable when I do the suctioning. Just breathe normally. Breathe normally. Okay, ready?
Ready?
on 3. 1, 2, 3. Perfect. Breathe normally. Everything fine? Perfect. Yes. So, Massimiliano, what can you tell me about Sophie?
Lady Sophie, she was extubated today because her condition has been improved in the last 2 days. Her septic shock is completely resolved, and she is not anymore on most of the effective drugs, so she's been improving in the last days.
So there's no organ insufficiency, so all organs are working normal, we have no organ support.
Yeah, exactly.
Okay.
Cardiac function is completely restored, and also the kidney function is going well.
Okay, perfect. Did she started eating already?
Yes, she started eating today, and also she has been mobilized out of bed in a chair.
Okay, perfect. Looks good. So she can be discharged tomorrow, right?
Yeah, the program is that one. If everything is like this tomorrow, she will be discharged in the ward.
Okay, okay. Good, perfect. Thanks. In the afternoon, we do a handover from the day shift to the night shift. Important information will be exchanged so that I can take care for the patients during the night.
In our ICUs, you will see the interprofessional team. You will see doctors, nurses, health nurses, physiotherapists, you will see social workers, and many people working in the ICU from other specialties like the consultants, or sometimes you can see people who are helping ICU patients for different things. We are an interprofessional team. The teamwork is important because any outcome in the ICU is the result of how we work together and how we are structured and able to deliver the best critical care for our patients.
Hi Silvia, how are you?
Fine, thank you. How are you?
Fine, thanks. And she is Sophia. Do you remember Sophia?
Yes, from yesterday.
Sophia, she is Silvia. She's the nurse who is going to take care of you for tonight.
Hi.
You could see she is really improving. We were able to stop her medications, inotropic and vasopressor. We were able this morning to reduce ventilatory support, and then this afternoon to stop ventilatory support and remove the tube. And she is also able to swallow. We try with water and then with food. So we were able to remove her nasogastric tube. So she is really, I think, feeling better.
Yes. So tonight, it seems to be a quiet night. You will be able to have some rest. I will put the lights a little bit off and the sounds, the less sound of possible, so you can have some rest. And tomorrow you will be able perhaps to go out from the intensive care unit. Okay, if ever you need something, you call me, I will be there.
Okay, thank you very much. Perfect, I leave you in really good hands. See you tomorrow. See you tomorrow. Bye.
Bye.
During clinical rounds, we assess whether patients have symptoms that we need to control. We usually do that with doctors and nurses as well as all the professionals during clinical rounds. We are very much paying attention to whether patients are painful. We not only assess pain intensity and pain distress, but also response to pain therapy as to be sure that pain is controlled. Other symptoms like distress, anxiety, hunger, and thirst are also symptoms to which we pay attention, and we are making our best to control these symptoms several times a day.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Good morning, everybody. Lino?
Yeah, I'm here.
Good morning, everybody. My name is Samir Jaber, and I'm very happy to co-chair this symposium Fresh Care that we want to thank with my friend Salvatore Maggiore. I let Salvatore start the introduction.
Again, hello everybody. Thank you, Samir. Welcome to this symposium co-organized by Fisher & Paykel and ECICM. The topics are new indication of nasal flow, and we are very excited to have excellent speakers from several parts of the world, actually. And it's my pleasure to introduce the first speaker, which is Dr. Carlos Ferrando from Barcelona, Spain, who will talk about indication of nasal flow in the post-operative patients. Carlos?
Welcome to this symposium. I'm Carlos Ferrando. I'm an anesthesiologist and responsible of the Surgical and Trauma Intensive Care Unit at the Hospital Clinic of Barcelona, Spain. The topic of the lecture today is post-operative high-flow oxygen therapy. So this is my conflict of interest. And today's lecture, for the next 15 minutes, we're going to talk about the prevalence of postoperative pulmonary complications, some factors associated to these postoperative pulmonary complications, the physiological benefits of the high-flow oxygen therapy, and the high-flow oxygen therapy in postoperative patients. As you can see in this slide, reflects really good the high incidence of postoperative pulmonary complications that we have in moderate to high-risk surgical patients. Some examples in randomized controlled trials in abdominal surgery. As you can see, the prevalence of these postoperative pulmonary complications is between 30 to 40%. Some studies show less prevalence, like the Provis study with 22%. Now, at the bottom of the slide, you can see observational studies. One of the most important ones, Las Vegas study, that it showed that the prevalence of PPCs were 10%, but close to 20% in high-risk patients. And the last two are patients under thoracic surgery, moderate to severe postoperative pulmonary complications, as you can see here, 18 to 11%. So we can realize with the data that the PPCs are a real problem that we have to try to minimize as much as possible. There are different factors that affect the appearance of postoperative pulmonary complications. Some are related to the patients, others to the surgery. There are some factors related to the intraoperative anesthetic management and how we treat our patients, like the ventilation, fluids, or the appearance of hypoxemia. And there are some others during the postoperative period, like the presence of postoperative atelectasis, the neuromuscular blockers, the airway status, or fluids. So all these factors should be realized, and we should try to minimize the appearance of some of these factors to decrease the prevalence of postoperative pulmonary complications. What happens in a postoperative patient? Well, it has some risks, those patients that are extubated after extubations, to develop a postoperative respiratory failure and other postoperative pulmonary complications. We have changes in the airway status to laryngeal edema or laryngospasms. We have changes in lung aeration because the appearance of atelectasis. We have changes in the neuromuscular function because some surgical factors or anesthetic factors like the use of neuromuscular blockers or the presence of pain. So all these factors promote the appearance of post-extubation acute respiratory failure or the development of other postoperative pulmonary complications. So why the high flow oxygen therapy can benefit to reduce these postoperative pulmonary complications. So these are some physiological benefits that were described by Golliger in this really nice review. And as you can see, he summarized the benefits, the physiological benefits in 5 points that may improve clinical outcomes of the patients. For example, we know that the high flow therapy heats and humidifies the inspired gas, and this improves the secretion clearance and decreases the bronchoconstriction. We know also that one of the main factors that are positive to reduce or to improve clinical outcomes is the washout of upper airways, decreasing the dead space. Also, the high nasal inspiratory flow decreases the nasal resistance. And, well, with high flows, we know that there are some kind of positive airway pressure favoring a recruitment of the atelectatic lung regions. So all these reasons are the reasons that in this subpopulation of surgical patients may decrease the appearance of postoperative acute respiratory failure and the appearance of other postoperative pulmonary complications. So I'm going to show you some examples of some trials that have shown in some surgical procedures benefits using this strategy as a preventive strategy to reduce PPCs or to reduce other outcomes, and some of them that have been used to treat postoperative hypoxemia or postoperative acute respiratory failure. This is a study performing cardiac surgery patients. They include, well, 96 patients more or less, and they were randomized to use high flow oxygen therapy or standard oxygen therapy. In the group of patients with high flow oxygen therapy, high flow was used with 30 liters per minute during the first 24 postoperative hours, and the main outcome of this trial was hospital length of stay. And as you can see in this graph, was significantly reduced this hospital length of stay in those patients, those postoperative patients after the cardiac surgery in where the high flow oxygen therapy was applied. This is again another study in postoperative cardiac surgery patients. In this case, they compared the use of high flow oxygen therapy to the use of non-invasive ventilation in more than 800 patients with some interesting inclusion criteria. So they include patients with a negative spontaneous breathing trial. They include patients with a post-extubation acute respiratory failure, and they also include patients with a high risk of post-extubation acute respiratory failure. And as you can see in the Kaplan-Meier curve, they did not show differences between these two strategies. So those patients with high risk, those patients that develop a postoperative acute respiratory failure, or those patients that had a negative spontaneous breathing trial but were extubated, well, we can choose both strategies. There is no benefit of one over the other one. So again, the high flow oxygen therapy demonstrates that it's a good strategy in postoperative cardiac surgery patients. We also have evidences in other type of surgeries, for example, after one lung ventilation. In this case, on this study was patients undergoing thoracoscopic lobectomy, and they applied this high flow oxygen therapy to in the study group and conventional oxygen therapy in the control group. When they used the high flow oxygen therapy, the strategy was to use a flow between 30 to 60 liters per minute. And as you can see, hypoxemia was significantly reduced when compared to conventional oxygen therapy, and reintubation and the need to escalate to non-invasive ventilation was also significantly lower when we use high-flow oxygen therapy in the postoperative period in these patients undergoing one-lung ventilation. But how about abdominal surgery? This is one of the most famous trials, the OPERA trial from the Foutier group. In this study that they include close to 200 patients, they did not show benefits in the postoperative period of using this high-flow oxygen therapy with this strategy with a flow of 50 to 60 liters per minute during the first postoperative day. So when they compared this high-flow oxygen therapy, they did not show a reduction in postoperative pulmonary complication compared with usual care that was a conventional oxygen therapy. And well, a really nice sub-analysis that they performed in this study was the one that I'm showing you here. So they stratify or divide the population in those patients that during the intraoperative period were managed with an open lung approach, with an open lung strategy, which means recruitment maneuvers and higher levels of PEEP, and the other group, those patients that did not or were not performed this open lung approach. And as you can see in this Kaplan-Meier curves, to those patients that were not managed during the intraoperative period with this open lung approach, the strategy of using high-flow therapy during the postoperative period did not show benefits. However, in those patients in which the high-flow oxygen therapy was used, the open lung approach was used during the intraoperative period, the high-flow oxygen therapy during the postoperative period showed benefits in reducing the prevalence of postoperative pulmonary complications. So in abdominal surgery patients, the OPERA trial showed no benefits in the overall population, but when they analyzed the population in which the intraoperative period was applied, an open lung approach, the high flow during the postoperative period showed benefits in reducing PPCs. This is similar to results that we show in these morbidly obese patients undergoing abdominal surgery. Was a small trial, just 64 patients. In all these patients, an intraoperative open lung approach was performed. We start using the high flow therapy before we extubate the patients, and we use a flow of 60 liters per minute during just the first 3 postoperative hours. And we show a significant reduction of postoperative hypoxemia and postoperative atelectasis. Was not significant, the reduction of the acute respiratory failure. Nevertheless, while this study was empowered to see a benefits in these outcomes, the main outcome was postoperative hypoxemia. So again, this is another trial that demonstrates the benefits of high-flow oxygen therapy in abdominal surgery patients in which an intraoperative open lung approach is applied. So which one is the recommendation nowadays for postoperative patients? These are the recommendations of the European Society of Intensive Care, and they recommend the use of high-flow nasal cannula or high-flow oxygen therapy in high-risk patients and or obese patients following cardiac or thoracic surgery, and this is a conditional recommendation. They do not recommend the use of this therapy in patients undergoing abdominal surgery. And well, we think we need to think about this, not knowing the results of the sub-analysis of the OPERA trial, and this is why my proposal is to individualize the use of high-flow oxygen therapy or even the use of non-invasive ventilation during the post-operative period. We strongly believe that this therapy should not be applied to every post-operative patient and should be individualized to the patient needs. We use this approach, as you can see in the point number 3, the post-operative patients. We use individualized NIV in the IPROF trial that we published in the Lancet Respiratory Medicine in 2018. But we are also performing now a big trial in patients undergoing thoracic surgery, in which we individualize the use of the high-flow oxygen therapy to those patients. So we do not use high-flow oxygen therapy to every single patient after thoracic surgery. We individualize the use of this high-flow oxygen therapy. So thank you very much.
Thank you, Dr. Ferrando, for this nice presentation. First of all, I would like to remember the audience. I encourage you to write questions for the speakers into the chat in order to forward your question to the speakers. One short question for Dr. Ferrando. You clearly illustrate the difference between high-risk patients, obese patients, those undergoing cardiothoracic surgery and abdominal surgery, with results for postoperative patients undergoing abdominal surgery which are not so clear, the results from the results of the OPERA trial. Samir Jaber is the senior author of the study. So we have from one side not conclusive results about the role of nasal flow in this patient population, and on the other side we have good results from use of non-invasive ventilation. So you clearly talk about trying to individualize treatment. So my question for you is very practical. From your experience, really at the bedside, how you decide one patient to receive nasal flow or non-invasive ventilation? You have some strategy, you have some clinical parameters to decide what kind of device to use in this particular patient population?
Well, thank you very much. This is a really interesting question. The real is that we do not have anything to decide which one is the best strategy. So we can decide if the patient needs some type of therapy, high flow or CPAP or NIV. For example, when it appears some desaturation during the immediate postoperative period. This is, I think, one of the most important indications when the SpO2 decreases or drops after extubation in the PACO unit. But we do not have data comparing the benefits or the efficiency of the high flow versus the NIV in abdominal surgery patients. I strongly believe that probably the high flow therapy is better because it's much more well tolerated by the patient that just have arrived from the surgery. It's very difficult for some patients to tolerate a face mask or a helmet just after extubation. So this is why we decide that probably the high flow therapy is better. It's more tolerated, so you can stay with this therapy for a few more hours and is not rejected by the patient. But we do not have data.
Probably also the combination of two techniques could be another option, just to make intermittent non-invasive ventilation together with nasal flow within NIV breath. Thank you very much, Dr. Ferrando. So, Samir, would you like to introduce our next speaker, my Italian friend Federico?
Thank you very much, Reno. It's my pleasure to introduce the next speaker, Federico Londini from Italy, about the use of high flow nasal cannula in the COPD exacerbation patient. Thank you, Federico.
Good morning, I'm Federico Longhini and I will speak about the use of high-flow nasal therapy as initial ventilatory strategy in COPD exacerbation. These are my conflict of interest. Chronic obstructive pulmonary disease is generally characterized by some periods of exacerbations. During exacerbation, patients may experience some acute respiratory failure characterized by acidosis and hypercapnia. Today, the ERS-ATS clinical practice guidelines suggest, or better, strongly recommend for non-invasive ventilation when a patient with COPD exacerbation is characterized by the presence of hypercapnia and acidosis. However, we also know that from the literature that when a patient has a very, very low pH, so the lower is the pH, the highest is the rate of failure of non-invasive ventilation. And this is mainly due by, as described by the study by Enzo Squadrone, NIV failure is mainly due to NIV intolerance, so to the intolerance of the interfaces. In this scenario, should high-flow nasal therapy play a role? Yeah, actually, some rationale for the use of high-flow nasal therapy in acute exacerbation of COPD patients exist. First of all, we should remember that the COPD patient with acute exacerbation have an increased quantity of sputum, so they are hypersecretive. The application of cold and dry gases mixture may injure and impair the ciliary beat frequency and the mucus transport velocity. The ciliary beat frequency and mucus transport velocity are optimal when the gas mixture provided to the patients is heated at 37 degrees and with a relative humidity of around 100%. Moreover, high-flow nasal therapy provide high gas flow that decrease the upper airway dead space like a transtracheal airway insufflation. So, provided by nasal cannula here, the high flow through the nasal cannula, the upper airway dead space is cleared out from carbon dioxide, and therefore there is a reduction of the dead volume of that space of about 70 milliliters. The washout effects is higher at increasing the amount of the flow rate and increasing and prolonging the time of expiration. Therefore, the higher is the gas flow provided to the patient, the better will be the washout effects. Moreover, when the patient has a longer expiratory time, that means lower respiratory rate, the washout effect is better. In addition, high-flow nasal cannula may counterbalance the presence of intrinsic PEEP. As you know, COPD patients are characterized by high-flow expiratory expiration limitation that creates a intrinsic positive and expiratory pressure, which is increase the workload of the patients during the breath. The application of high-flow nasal therapy with a closed or open mouth generates a low amount of positive and expiratory pressure, which may counterbalance the intrinsic PEEP. Of note, the higher is the flow rate, the higher is the generated positive and expiratory pressure. The sum of these effects may explain this data we have recorded in exacerbated COPD patients. As you know, here we have we enrolled 40 patients that were randomized in a crossover model to Venturi mask or high-flow nasal therapy during NIV breaks. On the left, we have the displacement of the diaphragm measured through the ultrasonography, and on the right, the thickening fraction, which is a measure to estimate the activation of the diaphragm. As you see, the displacement of the diaphragm was similar among NIV, Venturi mask, and high-flow nasal cannula. However, to generate the same volume and therefore the same displacement of the diaphragm, during Venturi mask, the diaphragm had to activate about 40% more than high-flow nasal cannula. That means that high-flow nasal cannula may have also a role in reducing the work of breathing of the patients. Based on this data, we designed this non-inferiority randomized clinical trial, a multi-center randomized control trial conducted in Italy, with the aim to assess if high-flow nasal cannula was non-inferior to non-invasive ventilation with respect to carbon dioxide, arterial carbon dioxide, after 2 hours of application of the treatment. Patients included were mainly COPD patients with a pH, arterial pH between 7.25 and 7.35, and arterial partial pressure of carbon dioxide greater or equal to 55. The study was conducted and we randomized 80 patients, 40 allocated to high-flow nasal cannula and 40 to non-invasive ventilation, and during the study we faced with some switch of treatment. At the end of the 6 hours, 30 patients allocated to high-flow nasal cannula switched to non-invasive ventilation, while 3 patients allocated to non-invasive ventilation switched to high-flow nasal therapy. This was mainly because or intolerance of the interfaces or due to poor gas exchange improvement or severe dyspnea. In the per-protocol analysis, we here have seen that both the high-flow nasal therapy and non-invasive ventilation showed similar decrease from the baseline of carbon dioxide, of arterial carbon dioxide, and therefore the high-flow nasal therapy was non-inferior to non-invasive ventilation with respect to arterial partial pressure of carbon dioxide, either at 2 hours after randomization and after 6 hours. Of note, after 6 hours, patients with poor tolerance to non-invasive ventilation were to 74%, while in only 35% of patients had poor tolerance, reported poor tolerance to high-flow nasal therapy. This difference was statistically significant. In another study published in 2018, Lee and colleagues observed 2 groups of patients randomized to receive or high-flow nasal cannula or non-invasive ventilation in patients with acute exacerbation of chronic obstructive pulmonary disease with a median pH value of 7.32. The intubation rate and the 30-day mortality was similar between the 2 treatments. Moreover, they also found no differences in gas exchange after 6 and 24 hours from the treatment. In this study, published in 2019, Sun and colleagues observed 39 patients randomized to high-flow nasal cannula and 43 patients to non-invasive ventilation with respect to the failure rate, which was similar between treatments, and also the cumulative survival rates, also not different between treatments. Of note, the need for airway care was higher with non-invasive ventilation, and while the duration of the device application was higher with high-flow nasal cannula. Today, which recommendation or suggestion we have from the literature? Well, in last year, in 2020, Rockwerk published with an expert panel the possible role for high flow nasal cannula in respiratory support strategy in adults. The authors focused on all types of acute respiratory failure, but they didn't faced with the hypercapnic respiratory failure. To be complete, with the European Respiratory Society, we have conducted these clinical practice guidelines on high flow nasal cannula and acute respiratory failure. Such guidelines are not published yet, but they are in press on the European Respiratory Journal. In the question number 8, we compare high flow nasal cannula and non-invasive ventilation in patients with acute hypercapnic respiratory failure. And as a panel of experts, we concluded after a great strategy and a methodological analysis of the studies, we suggest today for a trial of non-invasive ventilation prior to use high flow nasal cannula in COPD patients with acute hypercapnic respiratory failure. This suggestion is mainly due to the poor quantity of data present now in the literature, and therefore probably in the future this recommendation may be changed with the entry of new data. However, high flow should be considered and preferred over conventional oxygen therapy, that means for example, Venturi mask, during breaks of non-invasive ventilation, but also in exacerbated COPD patients, as high flow, as we have seen, significantly reduces the activation of the diaphragm and improves the comfort without affecting the gas exchange. Therefore, to conclude, in exacerbated COPD patients, high flow may be used as alternative to non-invasive ventilation in case of, for example, intolerance of the interfaces. As alternative to conventional oxygen therapy, as we have seen from the recent guidelines from the European Respiratory Society, because it reduces the respiratory effort, the activation of the diaphragm, and assure good gas exchanges. There is also indication to use high flow after extubation of COPD patients or at NIV withdrawal.
Thank you, Federico. Samir, any question for Federico? Otherwise, we have a question actually for the panel.
Yes.
But
I have one question. Federico, first of all, thank you very much for your nice presentation on the most recent data that you presented. I have a question of your practice. Did you observe in some patient, in some COPD patient, when you applied high flow oxygen therapy, some patients worsen their status with induce more hypercapnia due only because they received only oxygen and there is no ventilation with non-invasive ventilation? Did you have some cases with this type of patient and you stopped high flow rapidly to use high flow not alone but with non-invasive ventilation, as we need ventilation in this patient, not only oxygen?
Yeah, this is a good question. Thanks, Samir, and thanks also for the kind invitation. So, yeah, the main problem with exacerbated COPD patients with the oxygen is that you do not need to exceed the 92-94% of peripheral saturation. Otherwise, you will induce hypercapnia. And we all know the physiological reasons of that. So, if you provide high flow nasal cannula, oxygen therapy as you prefer, with an inspired oxygen fraction in order to, with a target of 92-94% of peripheral oxygen saturation, that's be really okay. For sure, if you could have a worsening of gas exchange if you exceed with the oxygenation, but this is true for conventional oxygen therapy. This is true for high flow. This is also true for non-invasive ventilation. This is just a target of peripheral saturation you have.
So, Federico, in your practice, could you help us to say what are the main settings that you use in terms of flow, in terms of FiO2, and in terms of target of oxygen saturation? I understand that you said probably oxygen saturation could be around 90, something like this. Could you remember for us?
Yeah, so if I was in a emergency room, emergency department, and I have a patient with acute exacerbation of COPD, and the patient that cannot receive non-invasive ventilation for some reason, that remains the first standard approach, I will shift to high flow nasal cannula with 60 liter minutes of flow. That's really important. Then I will start with this, and if the patient will not tolerate the high flow, I will just escalate to 55, then 50, and so on. The temperature is also important. We know that comfort is maybe modified by the temperature of you give the air. So around 31, 35 of Celsius degree for the temperature. And the last question was, inspired oxygen fraction. I will start with an inspired oxygen fraction to have 90-92% of peripheral oxygen saturation. Then if the patient will improve gas exchange, so CO2 should decrease, and the hypoventilation should improve, the oxygen will also increase, so you need to modulate in order to keep the target of 90-92% of peripheral oxygen saturation.
Thank you, Federico. Thank you.
Thank you.
Excellent, thank you. So it's time to move to our last speaker. It's my pleasure to introduce Dr. Dingyu Tan from Yangzhou, China. We talk about the use of nasal flow in COPD patients after extubation. Dr. Tan?
Mr. Chairman, distinguished colleagues, it's a great pleasure for me to be here and an honor to present my speech about high-flow oxygen therapy on post-extubation of chronic obstructive pulmonary disease patients. This is my statement on conflict of interest. I'm from Northern Jiangsu People's Hospital, which is a university teaching hospital in eastern China. It has a history of 120 years and now is the largest general hospital in the region. Our hospital has more than 250,000 emergency visits each year. We hope to have an opportunity to communicate and share with you in China in the future. My presentation will be divided into the following three parts. I would like to start by briefly reviewing the role of non-invasive ventilation in COPD patients after extubation. Acute hypercapnic respiratory failure is a common serious complication of COPD. Invasive mechanical ventilation is often required for severe cases. However, invasive ventilation is associated with increased incidence of ventilator-associated pneumonia and may increase the difficulty of weaning. In up to 23% of hypercapnic patients with chronic respiratory disorders after planned extubation, acute respiratory failure may occur within 48 to 72 hours. 30% of these post-extubation patients were reintubated within 7 days. It's reported that COPD accounts for about 70% of hypercapnic chronic respiratory failure. Hence, it's challenging to reduce the value of extubation in COPD patients. Many studies have shown that non-invasive ventilation applied immediately after extubation may prevent reintubation in patients at a high risk of extubation failure, including moderate to severe COPD. A Cochrane review showed that for COPD patients, a weaning strategy that includes non-invasive ventilation may reduce weaning failure and reintubation rates, shorten total duration of mechanical ventilatory support, and loss of ICU. Also, they can reduce rates of mortality and hospital-acquired pneumonia. Non-invasive ventilation is beneficial as a first-line intervention after extubation in COPD patients. Traditionally, when passing the spontaneous breathing test, COPD patients were extubated and received non-invasive ventilation. In China, the Pulmonary Infection Control (PIC) window as a switching point for weaning from invasive ventilation has been performed for many years. The PIC criteria include significantly decreased radiographic infiltrations, reduced quantity and density of sputum, improved temperature or leukocyte count, and downregulated ventilator settings. In a meta-analysis included 16 trials, the PIC window weaning strategy showed significantly improvement in mortality, VIP, length of ICU and hospital stay, and the duration of invasive ventilation compared to the conventional weaning strategy. However, non-invasive ventilation has its limitations, such as discomfort, claustrophobia, skin breakdown affecting eating and communication, which may finally lead to intolerance and non-invasive ventilation failure. Some patients also have contraindications to NIV. NIV failure may occur in up to 62% of exacerbated COPD patients, potentially leading to invasive mechanical ventilation. So, for post-extubation COPD patients who cannot tolerate non-invasive ventilation or have contraindications to non-invasive ventilation, alternative respiratory support methods are urgently needed. The second part of my speech is rationale for high-flow oxygen therapy in patients with acute hypercapnic respiratory failure. High-flow nasal cannula oxygen therapy is a new type of respiratory support system, which has been proved to be effective in treating hypoxemic acute respiratory failure, preventing post-operative ARF or reintubation after extubation in mixed population. Until now, there is relatively little evidence for the application of high-flow oxygen therapy in AHIF. However, in terms of physiological effects, high-flow oxygen therapy is suitable for AHIF in theory. High-flow gas or high-flow therapy can reduce room air entrainment, wash out naropharynx, reduce dead space ventilation and reinhalation of exhaled oxygen-depleted gas, and generate low-level positive airway pressure with sufficient heating and humidification. The combination of these effects can improve the efficiency of ventilation and oxygenation, counterbalance auto PEEP, reduce the breathing frequency and work of breathing, with good comfort and tolerance. In recent years, accumulating clinical studies have shown that high-flow therapy may be a potential therapeutic alternative to non-invasive ventilation for patients with COPD exacerbation and AHIF. Now, low-quality evidence indicates that high-flow oxygen therapy does not increase intubation and mortality risks compared to non-invasive ventilation. Some researchers compared the effects of high-flow therapy and non-invasive ventilation in COPD patients. High-flow oxygen therapy can keep arterial partial pressure of carbon dioxide unmodified, while oxygenation slightly deteriorates as opposed to non-invasive ventilation. The work of breathing is reduced by a similar extent to NIV, while high-flow therapy is more comfortable than non-invasive ventilation. Little and limited evidence for improved clinical outcomes is currently available. In the third part, let's review the clinical studies on high-flow oxygen therapy in COPD patients after extubation. So far, only a few studies have specially explored the application of high-flow oxygen therapy in these patients. A crossover study included 14 post-extubation COPD patients who were recovering from an episode of AHIF. After extubation, each patient received 2 one-hour periods of high-flow therapy, alternated with 1 hour of conventional oxygen therapy via a face mask. Compared to conventional oxygen therapy, the application of high-flow therapy post-extubation significantly decreased the neuroventilatory drive expressed by the diaphragm electrical activity peak and vocal breathing expressed by inspiratory transdiaphragmatic pressure time product per minute. The first RCT comparing the efficacy of non-invasive ventilation and high-flow therapy after extubation in COPD patients was published in early 2019. It was a single-center RCT, enrolled COPD patients who were intubated or for exacerbation with hypercapnia at the time of extubation and met the PIC criteria. 42 patients were randomly to receive high-flow therapy or non-invasive ventilation immediately after extubation. The primary outcomes were ABGs and vital signs at 3, 24, and 48 hours after extubation. We can see that at the same time points, there were no statistical differences between the high-flow therapy and NIV in respiratory frequency, PaCO2, oxygenation. There were also no significant differences in re-intubation and mortality rates between the two groups. But high-flow therapy had fewer pressure sore and better comfort. This study indicates that high-flow oxygen therapy is a potential alternative to non-invasive ventilation to wean hypercapnic COPD patients. A similar study published in this year enrolled 100 COPD patients who were extubated in the PIC window. The results of this study showed that the respiratory rate, PaCO2, oxygenation, dyspnea, and comfort score of the high-flow oxygen therapy group were all better than those of the non-invasive ventilation group after 48 hours. There was no difference in the re-intubation rate within 48 hours between the two groups. Our research team also explored the application of high-flow therapy after extubation in COPD patients. COPD patients with hypercapnic respiratory failure who were already receiving invasive ventilation were randomized to high-flow therapy or non-invasive ventilation at extubation at two large tertiary academic teaching hospitals. The primary endpoint was treatment failure, defined as either resumption of invasive ventilation or switching to the other study treatment modality. Finally, 44 patients in the high-flow therapy group and 42 patients in the non-invasive ventilation group were included in the analysis. The treatment failure rate in the high-flow therapy group was 22.7% and 28.6% in the non-invasive ventilation group, risk differences of negative 5.8%, which was significantly lower than the non-inferior margin of 9%. There were no significant differences between the two groups in intubation or treatment switch rate. Analysis of the causes of treatment failure showed that the treatment intolerance was significantly lower in the high-flow therapy group than in the NIV group. Kaplan-Meier curves showed no statistical differences in cumulative failure and survival rates between the two groups. 1 hour after extubation, the mean respiratory rates of both groups were faster than their baseline levels before extubation. 24 hours after extubation, the respiratory rate of the high-flow therapy group had returned to baseline, but the NIV group was still higher than the baseline. 48 hours after extubation, the respiratory rates of both groups were not significantly different from the baseline. The average number of the daily airway care interventions and the incidence of nasal and facial skin breakdown in the non-invasive ventilation group were significantly higher than those in the high-flow therapy group, while the comfort score of the high-flow therapy group was significantly better than that of the NIV group. Though our study indicates that high-flow therapy is non-inferior to non-invasive ventilation in preventing post-extubation treatment failure in COPD patients, there were some limitations to our study. First, the primary endpoint of this study was a composite one. Our sample size was relatively small. The settings of gas flow in the high-flow therapy in this study was based on each patient's tolerance level, which is subjective. The above studies explored the feasibility of high-flow oxygen therapy in COPD patients after extubation. A recent study explored the efficacy of combining use of high-flow oxygen therapy and non-invasive ventilation for post-extubation of COPD patients. It's a post-hoc subgroup analysis of COPD patients included in a multi-center RCT. Prophylactic use of non-invasive ventilation alternating with high-flow therapy or high-flow therapy alone immediately after extubation was compared. The main outcome was the reintubation rates within 7 days following extubation. The reintubation rate was 13% with non-invasive ventilation and 27% with high-flow therapy alone, whereas reintubation rates were significantly lower with non-invasive ventilation than with high-flow therapy alone at 72 hours and until ICU discharge. Mortality in ICU did not differ between groups. Well, that brings me to the end of my presentation. The last slide is a brief summary of what I have talked about. Physiological effects of high-flow therapy support its application in COPD patients. Accumulating clinical studies have shown that high-flow oxygen therapy might have a role as an alternative to non-invasive ventilation in exacerbated COPD patients. Limited evidence showed that the use of high-flow oxygen therapy as compared with non-invasive ventilation after extubation in COPD patients do not result in increased rates of treatment failure, while high-flow oxygen therapy had better tolerance and comfort. Further, large and high-quality RCTs are needed to clarify the role of high-flow oxygen therapy for post-extubation of COPD patients. That's all for my presentation. Thank you very much for your attention.
Thank you very much for this, again, nice presentation, very clear and nice data, which is totally in complementary with the previous one in this COPD patient. There is one question on the chat, which is coming from Jeremy. Do you think that the variability of flow, 50% in some of the cited studies, will affect the value of some of the studies, given that this is one of the main benefits of high-flow oxygen over standard oxygen therapy? In another word, I understand the question is, do you think the oxygen delivery may have an impact more than high flow really? And this is a question. Thank you.
Thank you, Mr. Chairman. It's an important question. That the oxygen delivered by the high flow oxygen therapy, we know that lots of studies has confirmed that high flow oxygen is effective to treat hypoxemic ARF. However, in COPD patients, there are some problems we needed to clarify in the future, such as we need large and high quality RCTs to clarify among COPD patients which patients might best benefit from high flow therapy. And also we needed to, especially for which patients may prone to be failure in high flow oxygen therapy treatment. And at this time, we cannot only consider oxygenation. We needed to explore the indicators that can predict high flow oxygen therapy failure. It's important. I think it's my answer. I hope this answers the question. Thank you.
Do you think that the ROX index could be one the surrogate to be helpful, as you said? The ROX index.
Sorry, could you repeat it?
Now, you said that we need to have some surrogate to predict success or failure. Do you think that the ROX index described by Jean-Damien Ricard on the Oriel ROCA, could be a surrogate to help this?
Now, the ROX index mainly used in the hypoxemic acute respiratory failure. And now, as far as I know, not enough study has been made in COPD patients, so we needed to do further studies. I think I had a little experience about the ROX index in COPD patients.
In the same way that the question I asked to Federico, what are your main setting and your main objective, your target of oxygen saturation in this type of patient? Do you have similar setting that described by Federico, or you have specific setting in post-extubation in comparison to acute exacerbation?
In the initial assessment, we use the same parameters such as flow, high flow about 50, temperature 37 degrees Celsius, and however, when we can adjust the high flow mainly due to the oxygenation and the patient's tolerance.
Federico, you said that you used 31 degrees, you said not 37, is it correct? You said different temperature.
There are some studies that show in hypoxemic patients that probably too high temperature are not so comfortable. So we start with 37. Then if the patient refers that the gases mixture is too hot, we decrease to 31. We should remember that 37 degrees is the optimal temperature if the patient is intubated, because we cross away the airways and so the anatomical airways. During high flow, we provide, if we provide 31%, the gas administered go through the natural airways, so they can reach again, they can increase again the temperature. So also 31 degrees should be fine. For sure, if the patient will tolerate 37 degrees, we will keep 37 degrees. It depends also, it's quite personalized on the patients we have and about the feedback we have on the comfort and tolerance. That's the main goal we have to avoid failure.
Carlos, do you have a similar setting? What are your main setting in the post-operative patient? Are there any difference? Are there any specific setting for temperature, for the flow, for the target of oxygen saturation regarding the FiO2? What are the specific settings in comparison to what said our two colleagues, Dingyu and Federico?
Well, I think one of the most important things of the high flow therapy is that it's easy to use, or much more easier than the NIV. And the settings are quite similar, even are different patients and usually hypoxemic acute respiratory failure, or just for a preventive strategy. I think that the flow as high as possible, no less than 40 liters per minute. If the patient tolerates highest flow, probably better highest flow. With this, we will increase the CPAP effect or the positive pressure. The lowest FiO2 to maintain this SpO2 over 92%. We need to remember that our healthy lungs, usually healthy lungs. And the temperature, I agree with Federico. We usually set close to 35, 36 degrees. Most of the patients, 37, they do not tolerate it. And we usually set a little bit lower temperature to improve the tolerance.
Okay. What are your main parameter or physiological variable or other do you use to see if it will be a failure or success when you applied? I don't know if it's different in a post-operative patient or in COPD. Carlos, maybe for post-operative, and Federico and you for COPD?
Yeah, I think that the ROX index even has not been validated in this specific population for post-operative patients, where these patients develop an hypoxemic acute respiratory failure, and the physiopathological reasons why they develop this hypoxemic acute respiratory failure are quite similar to other critical care patients. And this is why we think that the ROX index, and we have validated internally the ROX index to predict the technique failure, is very useful for us. Obviously, we do not decide to change the strategy, the approach, just because the ROX index, I think, is the combination of the ROX, the patient evolution, how the the respiratory rate, the sensation of distress. I think there are many other reasons when you are at the bedside that help you to decide or to know if the strategy is going well or not. But the ROX index is another tool that we use to decide, or at least to predict if it's going, the patient is going well or not.
Yeah, so for hypercapnic patients, to the best of my knowledge, there is no validation of ROX index in hypercapnic patients. As also Carlos said, for post-operative patients, we look at first of all, the clinical parameters of the patient. So as the patient is breathing, if there is respiratory distress, if there is tachypnea, we check and we monitor for gas exchange to arterial blood gases is fundamental. So if we see an improvement of the arterial blood gases and there is no increase of arterial pressure of carbon dioxide or a decreasing in pH, okay, the patient is going well, so let's go in that direction. Otherwise, if the patient is already in high flow because he didn't tolerate non-invasive ventilation, we try another rescue NIV session. Otherwise, he needs to be intubated if there is indication for intubation, that's for sure.
To find out, do you want to complete, or you have the same practice? No? So, I think it's time to conclude. Again, I want to thank all the speakers for their very nice presentation, the three speakers. I want again to thank my friend co-chair, Professor Salvatore Maggiore, and obviously thanks to the technical support and the ESIGN for the invitation, and obviously Fascia-PKL team, especially Richard Degas. Thank you. I enjoyed you a good congress. Thank you very much for all. Bye-bye.
Bye-bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Welcome everybody to this afternoon session, Best Oral Presentations. And we've got 5 presentations for you today, and I'm very glad to be joined by Giuseppe Citerio, and the editor of the Intensive Care Medicine Journal, our own journal of the Society. So, Giuseppe, shall we start with the first person? It is Mr. Reyes, Luis, I think is his first name, and the first poster that we had here is ICU care is associated with improved survival in COVID-19 patients. It was an analysis of a WHO clinical characterization protocol and database.
We have 3 minutes for the presentation, and we have the question after each talk, so be prepared to send the question over the chat. Thank you.
My name is Luis Felipe Reyes, and today I'm going to talk about our work entitled ICU Care is Associated with Improved Survival in COVID-19 Patients, registering the ISARIC WHO Clinical Characterization Protocol, a prospective, multinational, multi-center observational study. These are my conflict of interest. Then I want to start saying that around 20% of the patients with COVID-19 that are admitted to the hospital may develop severe infection. Then ICU capacity prior to the pandemic was suboptimal in many cases. Then this hospital have to expand their ICU capacity, and these patients were treated outside of the ICU by non-ICU trained people. Then we want to explore the clinical characteristics of these patients and also to assess the impact of being treated outside of the ICU by non-ICU people on clinical outcomes. We stratify our cohort between patients admitted and not admitted to the ICU. We use descriptive statistics to characterize the cohort, and then we use a generalized additive model adjusted by patients' characteristics, disease severity, treatments, organ failure, and healthcare system saturation to evaluate the impact of ICU admission. Importantly, we didn't have DNR orders on our data set. This is our flowchart. Then you can see that we enrolled more than 40,000 patients, and 50% of the patients were treated outside of the ICU. We enrolled patients in the 5 continents, and you can see here on panel B that patients admitted to the ICU were more frequently discharged alive in comparison to the patients that were not admitted in the ICU in panel C. And then 20 days mortality was lower after adjusting by all the variables that I mentioned before in patients that were admitted to the ICU, as well the 90 days mortality. Then we can conclude that mortality changed over the time, and then we can also say that more than 50% of the patients with severe infection were treated outside of the ICU. And also we can conclude that patients that were admitted to the ICU had lower mortality independently of age, gender, disease severity, and system saturation. So we encourage decision makers and physicians to take care of patients with severe COVID-19 in ICU beds by trained personnel. This is my contact information. Thank you.
Thank you very much, Dr. Reyes. Happy to see you online. And I have a first question for you while we are waiting for the question coming from the participant. You explained to us what you saw, that during the pandemic, being outside the intensive care, things that did happen more frequently in this setting, was associated with a worse outcome. What we can bring as knowledge for the future outside the pandemic, not only in the pandemic period?
I think that that's such a great question, and I think that for us as a critical care physicians, it's really important to be prepared for these kind of situations. So hospitals need to get ready before. We should have an expansion plan. We should have sufficient trained personnel to be able to take care of these patients inside the ICU. Because during the pandemic, people believed that what was important was maybe the invasive, the mechanical ventilators, or a specific treatment. But we know that taking care of a patient with severe disease is highly complex, and we need a prepared personnel, a team, and a designated environment to be able to do so.
Thank you. Do you have anything to ask?
So we've got one question here in the chat. Okay. What was mortality for the elderly? Did you try to specify that?
Punctually, the mortality rate in the older population was higher, as we already know. But when we control for all those variables, including system saturation, age, severe disease, then still we continue to see that relation that it was protective to being admitted to the ICU.
Okay, so I've got another question for you. So considering that one is in a pandemic and you know the outcomes that you've described, so what would you say? Is it more important to increase ICU capacity, or in terms of planning, do you find it more important to actually train non-ICU specialists with ICU skills? So what would be your preferred option?
I would say that we need a mixed alternative. So we need to have a dedicated space with a plan to rapidly expand the ICU capacity, but also we need to have a plan to use the non-ICU personnel taking care of these patients, all of them supervised by but an ICU expert as some of the plans that the European Society have proposed.
Thank you very much. We need to move on, and we are going to present the next speaker. Thank you for being with us.
Thank you. So the next speaker, we've got Margot van Mol from Rotterdam, and she is having a presentation on high prevalence of complicated grief among bereaved relatives after death of the patient in the ICU during the COVID-19 pandemic.
Welcome to this presentation. My name is Margot van Mol and I work as a researcher in Erasmus MC, an academic hospital in the Netherlands. I present this study on complicated grief also on behalf of my colleagues Sebastian Wagner, Judith Rietjes and Korstiaan den Uyl. We have received a grant from Evidence-Based Care by Nurses, and I would like to start with the conclusions. The COVID-19 pandemic, with quarantine measures and subsequently changed family-centered ICU policies, had a negative impact on psychological distress in bereaved relatives. The prevalence of complicated grief was high compared to the baseline, and communication and support as a quality indicator of care was perceived as low. This cross-sectional questionnaire study is part of a larger BRIC study in the Dutch ICU. We have normally 48 beds, which was upscaling to 72 beds during the COVID-19 pandemic. As a baseline, we had 127 bereaved family members from deceased patients in 2018 participating in cohort 1. And we started cohort 2 in September 2019. We continued during the first wave of COVID-19, which was group 2. Most respondents were the partners of the patient, they were female, and they had a mean age of 52 years. In cohort 1, the prevalence of complicated grief was measured at 14.1%. In cohort 2, the prevalence of complicated grief was in group 1, 1.3%. In contrast, in group 2, it was 48 to 6%. The means on psychological distress, such as depression, anxiety, and post-traumatic stress, we had the means and they were very high compared to the other groups. We also measured the assessment of communication with nurses and with doctors on a scale from 0 to 10. And before COVID, we had a mean of 8, and during COVID, it lowered down to a mean of 6. During COVID-19 pandemic, family-centered policies in the ICU were impacted with visiting restrictions, undesirable physical distance to the patient, and difficulties to involve the relatives directly. This study showed that worsening influence on the family members of those measures. And communication is a core aspect in situation in end of life, and that was very difficult. It is therefore of utmost importance to keep proximity and human relatedness. Thank you for listening, and I'm happy to take your questions.
Thank you, Margot, for this presentation. Thank you very much. It's obviously very stark data that you're presenting there in terms of what happened to relatives who had bereaved family members in the ICU during the first wave. Now, my question to you was, because you kind of focused on communication as being the primary kind of area that you focused on, do you think that there are other things that may have influenced also your results, like, for example, people not being able to be present, which is something that is quite important, isn't it, rather than just the part of the communication that is taking place?
Yes, thank you, Johannes, for this question. That is indeed a good point. I think that communication is, of course, more than only provide information. It is the interaction, and that was exactly what we were aiming at in the conclusion. So what we found is that communication was difficult, and maybe therefore we could not give enough information and also not enough support. And I think that we have measured in the high rates of of complicated grief, but also in the high rates of depression and anxiety, is exactly that we could not provide as nurses and as ICU team that humanity. And that was the most striking point also for the ICU members during the measures of quarantine. And very fortunately, we have had that behind us, and now the family members are welcome in the ICU. So what we already saw that the prevalences are lower down, and it's a better situation now for the relatives.
Thank you. Giuseppe.
I think it was an experimental not wanted to see how keeping the patient outside the unit highlight for us the importance of having this relationship inside the unit. So it was a very unprecedented time in which we explore what we already know, and probably for the future highlights the need of this relationship. I would like to thank you. I didn't receive any question. We need to move on for the sake of time. And thank you very much for your presentation.
Thank you, Margot. And
thank you.
We're going to go to the next presentation by Claire Woods on rehabilitation levels in patients admitted to intensive care with COVID-19 and observational cohort study. Thank you.
Hello, my name is Michelle Crinnage and I'm a respiratory physiotherapist from Coventry. This is an observational cohort study evaluating the rehabilitation outcomes of COVID-19 patients admitted to the ICUs at our hospital. Patients with COVID admitted to ICU often require prolonged periods of respiratory support, resulting in an increased risk of developing ICU-acquired weakness. Early and structured rehab can improve mobility status outcomes at the point of ICU discharge, although this is limited to patients who are invasively ventilated within a single centre. More research is required to understand rehab needs and inform and improve planning of ICU rehab services for future waves. The objectives of our work was to describe the characteristics and demographics, level of rehab and mobility status of patients admitted to ICU with a confirmed diagnosis of COVID-19, and secondly, to compare rehab outcomes between invasively ventilated and non-ventilated patients. The inclusion criteria is listed here on this slide. Rehab status was documented daily with Manchester Mobility Score to measure time to first mobilise, defined as sitting on the edge of the bed or higher, which is an MMS of greater than or equal to 2, and then highest level achieved by ICU discharge. Data was assessed for normality and compared using the student t-test or Mann-Whitney U test as accordingly. Categorical variables were analysed using the Fisher exact test. Total sample was 144 patients. Patients spent on average 15.2 days in ICU, with almost half, 47%, invasively ventilated. Ventilated patients were younger, non-significant, had higher Apache 2 scores, and spent longer in ICU. Mean time to first mobilisation was 9.3 days, with a median MMS of 4, standing with assistance, at the point of ICU discharge. Regarding ventilation status, there was no significant difference in the proportion mobilised, although ventilated patients were slower to mobilise, spent longer in ICU, and had lower MMS at the point of ICU discharge. Initial mobilisation was performed a mean of 1 day before patients had weaned from mechanical ventilation, although rehab delivery was inconsistent and delivered at a rate of 0.7 sessions per day, so every 2 out of 3 days. MMS at ICU discharge was significantly negatively associated with length of stay. Spearman's RHO correlation coefficient minus 0.321 with a p-value of 0.0001, following a near linear relationship with length of stay. In conclusion, early experience of the pandemic for physiotherapists at our trust illustrated high acuity of illness, with half the admissions requiring prolonged mechanical ventilation and high rehabilitation needs. Whilst the majority of patients were mobilised, this was on average performed the day before patients had completely weaned from invasive ventilation. Rehab delivery was inconsistent and overall mobility status at ICU discharge low, particularly for mechanically ventilated patients. Future research is needed to identify any modifiable causes for delays in initiation of rehab and inconsistency of delivery. Thank you for listening.
Thank you very much for the presentation, and I see another participant of the group answering the question because the speech was done by your colleague. And I think my co-chair has a question for you, and I would like to thank also all the rehabilitation staff that did work very hardly in this phase in which the access to the patient was a problem, and also rehabilitation. The importance of rehabilitation has been an important part of the recovery process, and I would like to thank all the rehabilitation staff. And please.
Thank you. So, Claire, I've got a question for you. When we looked at the statistics and what you described, I just was wondering, thinking back before the pandemic, do you think you would find a similar information between ventilated and non-ventilated people as you would found during the pandemic? Because I presume that you probably changed a little bit the way that you worked during the pandemic.
Yeah, I think we did change the way that we worked during the pandemic. Unfortunately, we didn't have sufficient depth of data to look at what we were doing prior to the pandemic. But yeah, I think we would have seen different outcomes.
We are missing your voice. We have some problem of connection. I don't know if Claire is able to return back with us. Claire, could you hear us?
Can you hear us?
Hello? Could you try to answer again shortly? Hello? Could you try to answer shortly again, if we are able to hear you? We have a problem of connection. We cannot hear you, unfortunately. Okay, for sake of the time, probably we can go ahead. Maybe we can return back at the end if there is time.
Yeah.
And if we have a better connection. The next speaker comes from Toronto, Canada. And the title is Achieving Lung and Diaphragm Protective Ventilation in Patients with Acute Hypoxemic Respiratory Failure, the Landmark 1 clinical trial. Please, Dr. Dianti.
Hi, I have no conflict of interest to declare. My name is Jose Dianti. I'm a fellow at the IDCCM at the University of Toronto, and I'll be presenting our study on the application of a lung and diaphragm protective strategy in patients with acute hypoxemic respiratory failure. Spontaneous breathing during mechanical ventilation in patients with respiratory failure can have both positive and negative effects. On the one hand, it reduces the risk of ventilator-induced diaphragm dysfunction, but on the other, when exaggerated respiratory efforts are present, it can lead to ventilator-induced lung injury and diaphragm overload injury. Therefore, a lung and diaphragm protective strategy may improve outcomes, but the feasibility of applying this strategy is unknown. So we decided a prospective physiological crossover trial to evaluate this feasibility. We include patients with a PF ratio less than 300 and bilateral infiltrates, and we applied a predefined algorithm to systematically titrate inspiratory pressure and sedation to achieve LDP targets of esophageal pressure swing between 3 and 8, and dynamic driving transpulmonary pressure below 15 centimeters of water. The algorithm was performed at a lower and a higher PIB level, which was randomized, and in patients on VV ECMO at minimum and maximum sweep gas flow. The primary outcome was the proportion of patients meeting LDP targets after applying the algorithm. We enrolled 30 patients, quite sick, with low PF ratios and high Apaches. 16 of them were on VV ECMO. At enrollment, no patient was breathing, so no one met LDP targets. After an initial phase where we reduced sedation to initiate spontaneous breathing, 20% of the patients met LDP targets, and after applying the titration algorithm, 67 met targets. Overall, the LDP titration procedure increased the probability of meeting LDP targets. As you can see in panel B, patients receiving VV ECMO were more likely to achieve targets than those not on ECMO. And panel C shows the effect of higher PIP on the probability of meeting LDP targets. Although on average there was no difference between higher and lower PIP levels, the effect of higher PIP on the probability of meeting LDP targets was markedly greater in patients whose lung compliance increased at higher PIP compared to those in whom lung compliance did not improve, as you can see by the difference odds ratios there of 24 versus 0.1. With a posterior probability of a subgroup effect over 99%. Increasing sweep gas flow had an important effect on respiratory effort in most patients, And the figure on your right shows that the effect of increasing PEEP on respiratory effort also differed according to its effects on lung compliance. We found that applying a lung and diaphragm protective ventilation strategy is feasible in many patients with acute hypoxemic respiratory failure, and that higher PEEP in selected patients and VV ECMO have an important effect on patient effort and on the probability of achieving targets. Thank you.
Thank you very much, Dr. Dianti. I think your feasibility study presented a result of the protocol could be applied. Which are the next step for you for testing these lung protective, diaphragm protective ventilation strategies?
Thank you for the question. So the next step would be to run a phase 2 trial evaluating the effect of the strategy on patient-centered outcomes, which would be a multi-center study here in Canada. And we will evaluate basically patient-centered outcomes such as mortality, ventilator-free days.
And do you think that this strategy could change mortality of this complex pathology?
Well, I do think so. I think it's important. The downside or complication is that it's a somewhat complicated procedure to apply, in the sense that it's not a straightforward thing. It requires some close, at least in our study, requires some close and tight titration of some parameters such as sedation and ventilation. So I think that would be like probably the main downside of it. But we also found that there are some adjunctive measures that aid in achieving these targets, such as you probably saw, ECMO or CO2 removal were spectacularly reducing effort and increasing the feasibility to achieve targets. PEEP also played a role. I didn't present it there, but we also, in patients who we just couldn't get into lung and diaphragm protective targets with either strategy, there was a last phase that included a partial neuromuscular blockade, so low dose actually neuromuscular blockade in sedated patients, and that also worked to attenuate the effort without increasing in respiratory stress or any adverse effects. So I think those could be sort of the strategies probably in the future.
I hope that you will succeed in having, let's say, an applicable trial in many centers in Canada in the future. And I thank you for your participation. I know that Claire, the previous speaker, the previous presenter, is online now, and we can have my co-chair presenting the question to the previous speaker if we are able to hear you. Claire, please.
Hello, hope you can hear me now.
Yeah, we can. So let's just continue there where we finished off. So if you were thinking about the time before COVID-19 and you were comparing those groups, what do you think are the main differences here? And what out of that, what do you think we need to do in the future?
Unfortunately, we didn't have sufficient depth of data to be able to compare our patients pre-COVID-19, but I do know that as a team we were providing more consistent rehab. Both our local and national standards were to provide rehab 5 out of 7 days, and we were falling short of that during the pandemic. What we don't have the data to know whether our rehab outcomes were any different prior to the pandemic, but we've put lots of changes in place since undertaking this work, so I hope that our rehab outcomes for our patients post-pandemic will now improve.
Brilliant. Thank you so much, Claire, and thanks for joining back in and all your effort during the pandemic. And we are now moving to the last speaker, who's Dr. Vihesaari from Finland, on the neurofilament light compared to neuron-specific analyze as a predictor for poor outcome after cardiac arrest.
Hello, my name is Lauri Vihesaari. I am from Kuopio University Hospital and University of Eastern Finland. Our study concerns prognostication after out-of-hospital cardiac arrest using neurobiomarkers. This is our study group and I have no conflict of interest. The motivation for the study was to find better prognostic tools for cardiac arrest patients. So far, neurospecific analyze NSE is the recommended prognostic biomarker in guidelines, but NSE has some weaknesses, so we compared new biomarker neurofilament light NFL to NSE. And here's our main results. Firstly, NFL has good prognostic value after out-of-hospital cardiac arrest in uninjected population And secondly, NFL demonstrated a better ability than NSE to predict poor long-term outcome. The study was a postdoc laboratory study of Finnish study, which was conducted between 2010 and 11 in 21 Finnish ICUs. We analyzed blood samples of 262 resuscitated patients at 24 and 48 hours after cardiac arrest. There was patients with both shockable and non-shockable rhythms, so the population was unselected. 48.9% of patients had poor outcome at 12 months assessed by cerebral performance category CPC from 3 to 5. NFL demonstrated a clear separation between patients with different outcomes. The median concentration for patients with poor outcome were more than 600 and 1100, and for those with good outcome, the concentrations were around 30 to 40. NSA concentrations were also higher for patients with poor outcome than for those with good outcome, but when we assessed the discrimination ability by calculating the areas under the receiver operating characteristic curves, those values were clearly higher for NFL than for NSE. In figure 1, there is a distribution of NFL concentrations according to outcome at 24 and 48 hours. Blue dots for patients with good outcome and red dots for those with poor outcome. We have two take-home messages. First, the novel biomarker NFL had a good ability to predict poor outcome after out-of-hospital cardiac arrest, regardless of initial rhythm. And secondly, the prognostic value of NFL was better than that of NSE. I thank you for your attention.
Thank you very much for your presentation. I have a question for you. The enrollment of a patient has been done a long time ago, years ago. So don't you think that changing the practice, for example, of TTM and others, could influence the result? And the second question, very short, is why do you focus on a single biomarker while we are thinking about a panel of biomarkers for predicting the negative outcome of a patient?
Thank you for those questions. The first question, yes, indeed, this is such historical data, and of course the TTM protocol has changed after that. But overall, those patients were not so different than nowadays, and the NSE work this time and the NFL values were in the line. And
do you want to wrap up? Sorry.
In the line with our present study after VF patients, so the Europes were lower than in our previous study, but I think that it is a good data, and we can use this historical data too. The second question, maybe we could use more biomarkers. There's GFAP and other biomarkers, but the NFL is so far the best one. In TTM sub-study, the Swedish colleagues found that NFL has the best prognostic value for predict poor outcome and find the patients with good outcome too.
Thank you very much, and thank you for all the hard work that you did by analyzing those samples and coming up with a new and additional method of things we might use as prognostic justification in the future for this patient group. Now, I'd like to thank Giuseppe Citerio for having been here with me this afternoon, and I'd like to close the session for best oral presentations now. So thank you very much, everyone.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Hello, good afternoon everybody, or good morning to America. That's me, Frankie, again from the studio in Channel 1. And I am delighted and pleasured to be moderating, together with our past president, Josef Kesecioglu, the session on high-risk surgery and how the anesthesiologist can prevent the long ICU admission. So we've got a fantastic faculty connected remotely. Arne Feldheiser from Berlin Charité, who is the chair of current anesthesia and perioperative medicine section of ESICM. We've got Professor Mike Grocott from Southampton, who is the UK Clinical Research Network National Specialist and lead for anesthetics and perioperative medicine in the National Institute of Academic Anesthesia. Hi. We've got...
Hi, how are you? Good to meet you.
Yeah, hi, hello. We've got Franco Carli from Montreal, Canada, who is the founder of the perioperative medicine program in the Montreal General Hospital. And he is the geek of ERAS. Hello, Franco.
Hi.
Greetings to Canada.
Greetings.
Monty Myton does not need any more introduction, a professor of anesthesia in the University College of London and national lead of one of these most successful ERAS programs in the UK. Hello, Monty.
Hi, thank you for the kind introduction.
Yeah, we are delighted to have you on board. And last but not least, Mike Scott from Philadelphia, United States, originally from Guilford and now the current president of ERAS. So fantastic faculty, which is at least diverse geographically to prevent the comments on social media. And what we are going to do now is I will hand over to Arne very quickly to give his introduction, and then we go around and you are supposed to give your best answer on the question that we stated in the beginning about the prevention of high-risk long ICU admissions after surgeries in the frail population, and then we will have a discussion. So, Arne, over to you.
Yeah, Frankie, thank you very much. I welcome you all to this round-the-table discussion. I'm very, very delighted as chair of the anesthesia and perioperative medicine section to have this elite, genius mastermind group of perioperative medicine. What's at stake? We have programs improving perioperative outcomes, like enhanced recovery after surgery programs. They had tremendous success in the last 2 decades, improving patient outcome with reduction of complications. And the point is, and at the intersection of intensive care medicine, we have a problem because where the data about very high-risk surgical patients is still scarce, and we still have a problem, how to cover these patients within, enhanced recovery after surgery programs. And so additional issues are needed to improve the care of these patients, and that's why we should have a discussion about the possibilities, how to further improve the outcome of these very high-risk patients, and how, especially in the pandemic, with reduced resources of an intensive care capacity and with a massive backlog in the present in the different countries, it's a crucial issue, how to define at first who has to go to the intensive care medicine unit, how we can avoid that the patient stays too long there, and perhaps we should start much earlier on, like rehabilitation. So I want to just pass the word to the different experts. And so what you think, how we can cover patients where we know that they are very high risk, how we can improve care for these patients, and how we can change perhaps the perioperative handling to improve care.
Okay, I will now encourage everyone who is watching to ask the questions over the chat function in the platform, so we are happy to ask your questions on your behalf. And now I kindly ask the experts to have a little round and answer and share their views on the topic. So starting with Mike Grocott. Mike, what do you think?
Thank you, and thank you so much for involving me in this very esteemed panel. I guess I'll be reasonably brief because there's a lot of informed opinion here. I think the two things I would say are, as with most things in life, preparation is everything. So the opportunities, as Arne touched on, for rehabilitation, so for optimizing physiology before surgery, and I tend to think about that in two separate regards. One is the behavioural type interventions, or interventions that you can put within a behavioural wrapper around exercise, nutrition and psychology, which have tended to fall under the label of rehabilitation. And then the second is the management of different comorbidities, so either within a perioperative medicine team or referring to specialist colleagues, the management of heart disease, lung disease, a whole variety of different things. So we have the best prepared patient. And wrapped within that, I think, is the part of the screening and assessment process which identifies the highest risk patients should be leading into a shared decision-making process which says, actually, maybe this is the wrong journey for some of these patients. Maybe, particularly with the complex cancer therapies, whether we should be thinking about the risk benefits of other approaches, including systemic anti-cancer therapies, and sometimes not doing anything at all, because I think we all see the sometimes dreadful consequences of surgery that goes wrong. And the second thing I'll say very briefly is the, and I guess we'll come back to this a bit later, but intriguing challenges between enhanced recovery and critical care. So we want to use all our clever monitors and our clever interventions, but that typically involves wrapping the patients up in a ball of lines and wires and everything else, and that mitigates against what we desire in terms of enhanced recovery, rapid mobilisation, getting them to walk to the end of the ward to have their first breakfast, for example. And I think there's some really intriguing challenges as to what the best environment is to do those type of things, how best to administer some of those drugs, peripheral vasopressors, and there are means of keeping the blood pressure up using tablets, and how we optimise the enhanced recovery bit sometime, and don't let the intensive care get in the way of that recovery. Thank you.
Mike, now that we are started with the discussion, something came into my attention when you were saying a very important word, and I would like to concentrate there for a moment, and that's the shared decision making. We are actually, I mean, we have even more handicapped patients here. There are not only people maybe who don't really understand the whole pathophysiology, but they are also elderly and frail. How shared is the shared decision making, and actually what would be the points that we would be taking care so that we actually maybe in principle at the end we think that we have shared something, but we have actually directed the patient towards an outcome. I think this is quite important. That's my number one. And then number two is who is talking with the patient, or who is at the background deciding the plan for the patient, because traditionally it's only the surgeon, but personally I see it a little bit different than that, also with the contribution of anesthesiologists and intensivists as the disciplines who take a long care of these patients pre and post-operatively.
Both really intriguing questions. So I think in the first, for the first question, there are two aspects to shared decision making. There's the sharing that we do within our broader clinical teams, and sometimes we're not great at that. So as anaesthetists or intensivists, we may not discuss with the surgeons as much as we could. We get pretty vexed and upset when the surgeons don't discuss things with us. But so I think the first element is discussing with the appropriate breadth of clinical team, which may well include oncologists, it might include nutritionists, so the whole spectrum of folk who might be involved in that. And then secondly, of course, the shared decision bit that involves the patient and the nearest people who are nearest and dearest to the patient. And part of that is establishing the degree to which patients wish to contribute to their care decision making. So some folk want to be told, they come to their physician to get just tell me what to do, please, doc. I don't want to have to worry about this. And some folk wish to have the highest degree of autonomy over that decision, and even if it's different from what we might judge to be the correct route, they wish to have the information and make that choice. And either approach or anything on the spectrum in between is appropriate. But I think it's very important to establish the framework within which that decision is being made. The second question, I think, is slowly getting better. This question, who makes the decision? In the best of all worlds, we'd all work happily together and come to a nice team-based approach. That doesn't happen. Certainly in our experience at the moment, it's particularly challenging because our surgical colleagues are struggling because of the challenge of getting operating time, because of COVID and the ongoing burden on the intensive care system, all the complexities, and they are understandably really personally upset about not being able to manage, operate on patients who they feel they can do something for, and therefore some of the decisions about both to operate and to, when you de-escalate from intensive care are being very pressured by that requirement to open up this precious resource, which is critical care. And obviously the easy answer is to say we'll make more critical care beds, but I think we all know that's certainly not an instant solution, and often not even an enduring solution. So it's about how we manage that resource best, but also how we work between us to accept for any particular patient who is going to lead that decision making. I don't think it is inevitably the surgeon. I also don't think it's inevitably the anaesthetist or intensivist. We've got to learn to play well together so the right person makes the right decision in the right context.
Okay, thank you very much. I don't know if there is anybody who wants to add something. Frank?
It would be nice to have other people's opinion as well, because let's frame it very practical. It is very burning practical question how to involve patients and at which stage. Does the team need to make heads around first and arrive to a conclusion what should be done and then communicate it with the patient, or to include the patient at the earlier stage when the opinions might be different? What do you think?
Or anybody else? Please.
I can take that on if you want. I totally agree. I think when you've got cancer, and it's discussed at tumour board, there has to be a discussion of options, but what isn't always put forward is the patient really a surgical candidate? So there needs to be a triage mechanism in your overall pathway. And one of the problems is that patients don't recognise the complexity and the risks of cancer surgery. You die not from the cancer normally at the time of the perioperative care, but a complication. And most people think heart surgery is the highest risk surgery, and they don't realise that having your esophagus or duodenum operated on is actually much more risky. And you don't die on the operating table, it's another process. So I think it's important to triage, take it down, give the options, and then the risk-benefit in context, individualising it to those patients' comorbidities and their frailty index, because we're looking at operating on more and more elderly patients. I think we're all aware with COVID that there is a limited number of not just operating rooms open, but ICU beds post-op. So it's even more important to streamline that process. And to sort of round it back to the very first question, if we have our framework towards what can we do to reduce post-operative ICU admission, as Mike says, you've got to look at the whole pathway. A good pathway is all about optimization before surgery, and identification of risk factors. The actual surgery should be minimally invasive with minimal blood loss. Then we have our bundle of care, or ERAS elements, whatever you want to call them. And two of the most important that we do as team anesthesia is basically perfuse the body well with fluids and hemodynamics, and then to get functional analgesia, minimizing opioids. And then if you've got that, it's about rapid de-escalation to eat, drink, sleep, mobilize. So then if you paint that as across the whole of the perioperative pathway, all we really need are macros to identify which patients are not keeping on that pathway and to follow those macros. So anyone who's identified with a problem, you have a macro for that to keep them on track. And then the challenge in medicine, I think, is to identify then which patients are failing. And that brings me back to the intensive care utilisation, because we don't really know the value of intensive care in the first 12 hours after surgery because of the fact that complications come often a bit later. And we have this huge void between the PACU, the post-anaesthesia care unit, and the or in ICU to the ward or floor. And I think the biggest hole in medicine at the moment is we go from, there's this huge gulf between someone getting an anesthesiologist looking after them perfectly to 4 hours later being waved to hourly or 2 hourly blood pressures. And that's where I'd like to bring in technology, because as Mike Grocott said, we don't want to tie people down, but there is on the horizon, I think within the next couple of years, sort of portable packs which will be able to do non-invasive, continuous blood pressure, pulse oximetry, and hemoglobin monitoring. And I think once we get that on our patients, it will be a completely different kettle of fish, because then we can effectively triage all our patients to who will benefit from critical care most.
Yeah. Thank you, Mike. Thank you. We are slightly, ahead in the process, so we were still discussing how to implement shared decision-making model, and I would be really interested in Monty's experience at the national level, because there is a track record of success behind you. So how did you achieve the implementation of the pathway that starts with identifying and consenting patients to it? Monty.
Well, thank you very much indeed, and echo my thanks to be on this wonderful panel. We've already called ourselves out for being a manel, so the tweets can stop now. We apologise to everybody for doing that. But back on subject, I'll give you my 3 billboards outside my retirement village, and that is no decision about me without me, which was one of the sort of T-shirt messages from our National Enhanced Recovery campaign. Please make sure that I, the patient, am at the centre of every discussion. The second one is, which we've referred to already, is that surgery is not always the right answer. So right patient, right surgery, right place, etc. And the third one, which I think is the key point that we're discussing in this section, is please measure how frail or not I am, and have a plan to do something about it. Now that's a big billboard, but I think the biggest step forward in our perioperative care was the wonderful engagement of our geriatric colleagues, led by Dr. Jagdeep Desai in particular, where you're bringing in expertise which is very specifically about the care of the older patient who is typically frail, and there are other people on the panel who can speak to frailty better than I can, how to evaluate that. And then once you've determined if a patient is or is not frail, because it's not measured by age alone, then let's make all those decisions informed by a realistic understanding with an expert about what I can expect depending on what happens next. So those would be my 3 big points. Me at the centre, surgery is not always the answer. Evaluate frailty, and as part of that, if I am frail, get an expert involved. Thank you.
Yeah, well, can you be perhaps more specific about the role of geriatricians in that process? Because it has been debated through this Congress a lot, but obviously, the role of physios is clear, nutritionists, patients who look after patients' organ dysfunction as well. But, the role of a geriatrician, indeed, as an expert in frailty, can you be more specific of what are the questions you ask?
So great point, because this is one of the great areas of collaboration, and possibly also in places becoming one of our battlegrounds, which we don't want it to be. There is an international shortage of anaesthesia providers. There's a bigger shortage in our country, in the UK, of expert geriatricians. So the important thing is that the right person with the right motivation, with the right understanding of the challenge, who identifies the frail patient and takes a holistic approach to address all the issues. And I personally don't mind who that is, providing that they're motivated and as expert as possible. There aren't enough geriatricians to go around, but having a conversation with them about how to best do this together, and then dispersing the workload seems sensible to me. Sometimes that will be from flash to bang, that will be a physiotherapist. Sometimes it will be a nurse. Sometimes it might be a nutritionist.
Right, thank you so much. Franco, when the decision is made, right, that we go on ahead despite all of the odds against the patient and all the frailty identified, can you summarize what can be done to minimize the risk of operation and prolonged ICU admission?
Okay, thanks very much for asking me. Well, I would like to just bring back for a moment the ERAS. When ERAS was very much based on the importance of reducing the stress intraoperatively and immediately postoperatively. And the only consideration preoperatively was education and the preoperative drink and so on. So fasting. It seems to me that what has been missing ERAS, and is still missing ERAS, is really the preoperative period. And I think, in essence, what we're discussing today is really I don't want to repeat what has been said eloquently by all of them, is the preparation of the patients. Now, this is not only to proceed, I think is really, we have a preoperative clinic. Are really functioning this preoperative clinic? That's the question that worries me, is that when we started ERAS at McGill and for North America, I remember our really trouble was to say, we cannot do it without a preoperative clinic. But preoperative clinic is not just an assessment whether you actually have anesthesia assessment and so on. I think it's much more than that. And that's where the interdisciplinarity comes in. That's where you have your geriatrician or internist and so on. And that's where it comes. Now, the question is that who is taking the leadership? Now, it's a shame that on this panel there is not a surgeon. But I think that the ownership of this, it doesn't matter who takes the leadership, but somebody has to take it in the whole thinking about. Now, we're talking about patient participation. Hold on. I mean, taxation without representation. And that's what's happening at the moment. The patient is taxed to obey, to do what we say, but it's not really contribute to anything. You just believe us. So that's the importance of the patient. But I would say that we have to have a gut to actually tell the surgeon not to operate. And now we arrive to that because our process starts with the rehabilitation, start not 2 weeks before, but 4 to 6 weeks before. So may start with the gastroenterologist who leads the surgeon, and the physiatrist who tells, or rheumatology, tell the orthopedic surgeon what to do and so on, or the neurologist and so on. So it seems to me that if we don't start well before, we don't have time to optimize the patients. I'm talking about, from our experience, very much, we are able now to say to the surgeon, do risk stratification. Mike said very clearly, we need to stratify the risk, assessing the patient's risk. And then we say, and this could be a screening, and then an evaluation, obviously. But what we need to do now, we have to pinpoint to the surgeon, collegially with the nurse, like the ERAS does it, but collegially and say, right, where are we? Have we optimized anemia? Have we optimized this, the cardiac failure? Have we optimized renal? Now, is the patient in good faith? Is he in good function? Good function. I mean, is he able to return to walk after? Is he malnourished? Malnutrition accounts for about 40% of our patients admitted to the hospital. I mean, per se, it seems to be that it's trivial, but it contributes immensely to the recovery aspect. So what I'm trying to say now, coming back, is screening. Having time preoperatively. I say that's what ERAS is missing, in my view, and that's what you should do. And then, of course, was mentioned frail and geriatrics. Now, geriatric, yes, I welcome the geriatric, but the geriatrician have to be able to understand what is the surgical trajectory, what the surgical patient is. And that's the value comes in cognitive assessment, obviously, frailty to some extent, and so on, absolutely. But I don't think the anesthesiologist should lose this concept of ownership of preparing the patient. And that's what I'm really struggling with the anesthesia community. That we have to take seriously, but if you take seriously, we have to really involve everyone, have the courage to the surgeon say, no, restage your cancer. Restage it. See whether really patients need a surgery or not. And so on. I stop here.
Okay, thank you very much. And I think we are now somewhere a little bit beyond the halfway. It would be nice to first wrap up a little bit what we have said so far, because I think there are some important statements are made. The first one was shared decision making, and if I hear a couple of the speakers so far, the shared decision making is a multidisciplinary project. At certain stages, one discipline or another should take the leadership, but we should have leadership. That could be the geriatrician, that could be anesthesiologist, but there should be more parties than the surgeon who is performing the operation alone. And then, if I understand correctly, Frankie's question was quite relevant. When are we talking with the patient? Are we talking with all of us with the patient? Probably that would be very threatening for the patient when he or she is faced with 5 different specialisms, but I think we should be coming together pre-operatively in a multidisciplinary fashion, and also with Franco, we should take time for that way before the surgery is planned, and when the decision is made, the patient is chosen, we should speak with the patient. And also what I heard Monty saying, which is for me a very important issue, actually the nice one was no decision about me without me, but even nicer one from my point of view, the statement that surgery is not the only option. So we need also to focus, and we really need to see whether the surgery will bring more damage than cure, and sometimes we need to find other solutions, I mean, maybe it would not go that far in many cases, but no option is also an option, and the comfort of the patient is also quite necessary. So this is something that I just got as a summary to our audience in the first half of our talk. Please correct me if I just have misunderstood something. Maybe just take 1 minute to react to what I said. If there are needs to be, there are certain things needed to be added, and then we go on for the second part. Any comments?
Okay, I only see thumbs up, which is great. So we understood you, perhaps. So let's move. Let's move on. Let's move on. And guys, well, very often during the high-risk surgery, the bottleneck is ICU beds. So can we predict, and what's your strategy of planning ICU admission after elective surgeries? Mike Grocott, perhaps give you your opinion.
So a generally difficult question that is particularly difficult at the moment for the reasons we touched on relating to COVID. I think, I mean, I refer you to my previous answer, a preparation and appropriate evaluation of the patient as a team so that everybody is in agreement with the approach is a good start. I'm always nervous if we objectively and as a team agree a particular level of risk. I'm always nervous when we decide that actually it will be fine, because simply because they got through theatre with a modest level of vasopressors and now they've come off and they appear to be fine. I don't think that seems a misunderstanding of the statistical models that we've created. We're not talking necessarily about immediate instability, we're talking about complications in the days following surgery. And so I clinically am pretty resistant, unless someone is clearly flying, to downgrading risk without good information. Now, I would love to see the world where actually we could use information from the intraoperative and immediate post-operative phase to say, actually now, we know this combination of preoperative risk and immediate intraoperative and post-operative journey is fine. We've seen this before, and so we can go to ward. But I don't think we're sufficiently informed at the moment, and I think we do the patient a disservice when we decide they look great, but actually the numbers say that's unlikely to be the case. But I mean, the key thing is appropriate, careful evaluation and teamwork to discuss, to agree that. So there's an agreed plan. We don't start fighting about who has burn and who doesn't have burn.
Do you think that plan should be just subjective and individualized based on assessment of each individual patient, or supported by some objective scoring system when you say, okay, in my institution, that kind of frailty combined with that degree of surgical risk means that we need ICU bed, and if we don't have it, we just don't proceed with the surgery? What do you think? Is it?
So I think it should be supported by objective data. I think we know from the MET study, for example, that subject to evaluation of physical fitness is poor. There are other data, so some of the SNAP data from the UK is interesting in that it suggests that the clinical end of the bed assessment may be not quite as bad as that, but it's still better when augmented with objective data, and actually a pretty limited objective data set. So I think, why would we not use objective data? I think the balance of evidence suggests that we're not great at assessment, and it's not that difficult to get the information together. It's just a case of having the systems in place. So the burden shouldn't fall on the clinician in a rush on the morning of surgery. The system should be there to have all the relevant data and the appropriate calculations, probably in a somewhat more sophisticated way. We can look at outcome-specific prediction. So it's not just about will you have a complication, will you die? It's which type of complication are you more likely to have, and therefore how can we more appropriately manage you on that basis? Delirium is wildly different from a chest infection, which is different again from a cardiac arrhythmia. So the more precision we can add to those estimates, both in terms of their likelihood and the character of the adverse outcome, the better.
And what actually of those objective scales do you use in your institutions, if I can ask the experts around? Because there is always a trade-off between the throughput and cutting corners with regard to safety. So, do you really use some objective assessments? And when you see the patients, do you actually tick some boxes and do some scales in your real life?
Can I expand that question a little bit more? Because I also have some comments that these sort of scoring systems are scarce, and they may be quite helpful, but not 100% accurate, if I'm not mistaken. Maybe Arne, can you make a comment on this? How can we deal with these patients?
Yeah, at the end, it's a big problem because we are, I would state, we are in a cloud of uncertainties with these patients still, according to the data out there. And this makes it really hard to have a precise prediction for an individual patient. And at least in the institution I was working in, never it came to a point that a score was influencing any decision. I don't know how is it in the other experts centers, but it makes it really, really difficult. And the best thing I've seen is to cover what presents the patient. Sometimes the responses of the patient to the things we do, inducing anesthesia, starting with the surgery, during the course of surgery, offers a lot of information we have to integrate further, because one thing is the decision prior to anesthesia, the other thing is reassessment during the course of anesthesia. And the biggest problem I personally recognized is you can do enhanced recovery, you can do a lot of things, being restrictive, go-directed fluid therapy, and then you still end up with vasopressor requirements. And then due to the problems of the ICU, the patient gets 3 liters in the direct post-op course to wean off the vasopressors and can be sent to the ward. This is a massive problem I see with post-operative care, where we still need new answers. More, I think, still with the uncertainty in pre-op, we need systems in place to recover these patients in a direct postoperative course.
Right, thank you so much. That was great. May I perhaps ask you to now, because we are, running into last 10 minutes of our talk. The thing is that with this, and now I will be moving towards the ERAS pathway, and given all the evidence around, it looks as though this intervention should be efficient in terms of answering our overarching questions, how to minimize mortality and long-term ICU admissions. However, it's not always easy logistically to implement it. It costs a lot of time. I know it's worthwhile for the sake of the patient's fate, very operatively, but can you, each of you, stress one component, one or two components that you consider the most important, and if we have to compromise somewhere, where would you just reduce the logistical burden?
Mike, maybe?
Mike, yeah, you start.
Mike Scott.
Yeah, Mike.
Yeah, sorry. There are two mics here.
You didn't speak too much, Mike. That's why we think you should say something.
I'm afraid I've got to throw two out. It's basically restoring function with optimal analgesia and avoiding opioids, so we're not poisoning the patient, and then perfusing the body, getting the fill flow pressure right of perfusing the body. Those would be my two.
Okay, so perioperative aspects. Monty.
So completely echo that, but I think the easiest way to articulate it is help your patients to live the dream. So we want everybody drinking, eating and moving as quickly as possible post-operatively. And if you agree that is the objective, and our national standard is set at greater than 90% for all forms of surgery, then you have a clearly understandable, tangible goal. Irrespective of how big the surgery was, I want them sitting up, ideally out of bed, eating breakfast. We know there are a few cases where you can't do that, but we understand the big picture. And you do that by achieving everything we've discussed to date. It's analgesia, it's your hemodynamic management, and it's addressing as many things preoperatively to help achieve that goal. So help our patients live the dream.
Franco, thank you so much. Franco, what's your view?
Yeah, my slogan is recovery starts before surgery. You got clear. If you don't get to optimize the patient before, and the risks are, we know that there is more chance, and I think that is leading to the postoperative. We know that it's 5-10% of patients go to intensive care, right? Let's say, okay, the 95% are really recovering longer. And that's the problem. Why we are not able to concentrate very much on, yes, the 5%, which is very difficult, we heard about, but I think expedite intensive care. Do everybody needs intensive care? How long should stay in intensive care? And then what's happened after intensive care when they go into ward? And that's something that the future we should look at. And where you guys, you intensivists, are really should be brought in with us before surgery and discuss with us the risk of postoperatives. And not just the postoperative, preoperative. I believe that a lot is about before surgery.
Does any of the speakers, including Franco, of course, can give us any clue how we can convince our board of directors and the insurance companies to invest money? Do we have enough data to show them that we are actually sparing money from the other side, the other end? Because people usually provide more money for things that they see happening to treat it rather than to prevent something which they don't see beforehand. Just feel free to say something.
Arne, European view.
I can state that there are many data out there showing that there's a return of investment. The stakeholders, the whole team is on board, and more or less data indicate that within an enhanced recovery pathway, you need an implementation rate of higher than 70%. The most important issue that there are very crucial elements like the others mentioned, pain control, circulatory flow control, they have to be included, but in any case, you need a very well implementation rate, then you get a return of investment. The data from Greg Nelson in Canada and Monty's data from Great Britain are, proving that, and it has to be a team effort. Everybody has to come together, and the point is, like Franco said, everybody has to be integrated. It's not easy to have an errors pathway the patient went through and everything is fine, then everything turns out well. But if there's a problem, how we cover these patients as fast as possible to nevertheless recover fast. And there is a crucial role of intensive care medicine, to cover the, if the patient comes not out of surgery as he should leave the surgery, then how to elevate him with a different thinking in the ICU, post-op ICU, then not to start intensive therapy, just to support his recovery. And this is something, it has to be brought into the issue for the very high-risk surgical patients.
Yeah, perhaps the intensivist mindset should be within the framework of early mobilization and achieving the goal that Monty mentioned, and that is, getting the patient back up to the feet. Mike Scott, can you comment on the financial model in the USA, whether it's different and how it's gonna help, or?
Yeah, it's very different here. Obviously, I've worked in the UK with Monty and Mike as well. I think the driver, I don't think we need the insurers or governments to tell us how to do this, and whether we call it IRAS or anything else. We just need to move to an episode payment bundle payment model, so episode payment, but with the risk-adjusted scoring for patients that are obviously got more comorbidities, because then it's really put back to the hospital to get the best use of resources and to drive all this, which means everything from the pre-operative clinic to IRAS to analgesia and goal-directed human dynamic therapy and rapid de-escalation of care and mapping your long-term results. So I think from high level, that's where it needs to go. And I think the US is very different because traditionally we've been rewarded for failure. You get a patient with more complications and actually the hospital system earns more money. But that's why it's turning now more to CMS are driving the episode payment bundle model, and so will insurers. So I think the high level is that's the direction we need to go in.
And Mike, are there any implications with regards of nurse anesthetists delivering anesthesia? Do you think the performance will be the same at the same level?
Yeah, so to back up, we're all talking about perioperative clinicians, that team anesthesia needs to be to own the preoperative part, to own the immediate post-operative part. We deliver anesthesia here very different in the US. It's all about throughput. And we have a team of nurse anesthetists that work with a anesthesiologist physician. So I'm often looking after 2 or 3 rooms at the same time. And there is emphasis over throughput rather than necessarily doing interventions that might reduce downstream complications. I'm not commenting about my own institute because we've got very good ERAS and we set quality as the standard. But I think from the whole healthcare community, it is very difficult when there's pressure on just turning the rooms over and getting patients through. So we need to back up again. And as I say, I think the only way to do that is for the financial modelling to change so that we are allowed to spend more time with the patients doing the right thing at the right time in their pathway.
Yeah. Okay, and that comes to the last question, which is to Monty. We are advised to engage people we don't have. And how do you convince your board of directors to, hire and appoint more expensive and scarce resources like geriatrician? And how do you convince them that this investment will pay back?
It's all about the data. Everyone's referred to it. We are, I think we call it lucky or unlucky, we are already in a risk-adjusted bundled payment model in the United Kingdom. Therefore, it's a healthcare manager's dream, enhanced recovery, because you do actually get a return on investment, which is unusual. It's, the dream turns into cash, hard cash, very quickly. So providing you've got the data and you've got motivated managers who are seeking to drive quality, and from quality you will deliver value and therefore a better margin, it's It's a no-brainer. If you don't have the data, you've got no hope.
Wow, it sounds so optimistic. And with that, guys, I think, let's, I mean, let me
Most of us don't
feel
have the
easy,
data, so
and
it's not
our audience too.
We are going with great comfort back home now, I think.
Yeah. Thank you so much. Thank you, my co-moderator, and all of this fantastic group of experts. And hopefully in a few years' time, we will see in our routine practice how it works. Thank you so much, and goodbye.
Thank you very much.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you very much.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
Because your patients can't wait. Because your mission is to buy time and save lives, we are here. To face emergency, we have adapted our manufacturing facilities and increased our production capacities. We are here to support you, offering access all around the world to the latest articles and sharing recommendations from the most experienced experts. Assisting the ICU community on how to manage critical patients is always our priority. Aspen delivers more than anesthetic products. It is because you are there for your patients that we are here for you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
Because your patients can't wait. Because your mission is to buy time and save lives, we are here. To face emergency, we have adapted our manufacturing facilities and increased our production capacities. We are here to support you, offering access all around the world to the latest articles and sharing recommendations from the most experienced experts. Assisting the ICU community on how to manage critical patients is always our priority. Aspen delivers more than anesthetic products. It is because you are there for your patients that we are here for you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
A very welcome for all of you. Thank you for watching. It was already a long day, and I'm very happy you are with us. And we will discuss the highlights with different chairs of the sections. And I'm very happy to see the chairs of the sections we have of today. We have the section of ethics with Christiana Hartog. We have the section of infection with Pedro Povoa, and Rika Ferrer from Barcelona, still working very hard, I can see, who will talk about the systemic inflammation. And finally, we also have Nicole Juffermans about translational biology. Well, thank you all for being there. We are going to discuss the important developments that we have seen over the past 1-2 years in the field that you cover with your section. And so let me start first with Christiana. Good to see you again, Christiana. I hope you can hear me very well. Ethics has been a very important factor that has been discussed by, I think, approximately everybody in the world during the pandemics. So can you tell us a little bit, from your point of view, the developments that we really need to know about ethics over the past 1 to 2 years?
Well, thank you, Amar. I'm pleased to be here and welcome the opportunity to speak about this. As you said, ethics has received a lot of awareness in the pandemic. And it's, of course, a timeless topic in a way, which that's also important to know. There's a lot of awareness now, or more awareness about some of the principles that underlie decision-making, maybe, and rationing and triage, but a lot of ethical topics have not really been discussed or are still in the background, like, dealing with the patients and with families, family visits. I think there are some issues that we need to discuss after the pandemic also, and things like patient autonomy and so on. So what I'm trying to say, ethic is not something that happens by itself, and it's not something that develops through media coverage, but it's something that needs standardization. It needs active implementation, training, and the quality of ethics must be managed also. So on one hand, I think it's good. It's a chance for ethics that we're in the limelight, but now the challenge is to keep the momentum going and to continue the development.
So according to you, which elements of the ethical discussion that we had about ICU patients, I want to focus on ICU patients, have got a lot of attention, and what should we learn from that? In the Netherlands, there was a lot of talk about what we call the black scenario, that there would be not enough ICU beds anymore. How do you see that?
Yes, I think that of course was a very scary scenario that touched everyone immediately, and that had a lot of media coverage. I think it's I think the issues, of course, go deeper. There are issues like justice, how about patients who don't have access to intensive care units? How about the underserved areas? And how about care in places where people don't have any intensive care units at all? And I think ethics touches many other areas. It's like a core area. I think we need to consider what are the lessons that we should learn, and also consider the lessons that have not been learned in past pandemics.
Well, tell us, what do you consider of one of the important lessons that we have learned from this?
I think it is that everything is interconnected. We don't have silos of different issues and disciplines and skills and so on, but they must all come together. they must really be intertwined. Now, this is something that we have tried to do in the Congress by, for instance, in this case-based fundamentals. We've just been talking about it, this training and teaching based on a single patient story and patient trajectory, and then bringing all the issues in as they become kind of urgent in the patient story. So I can't, you won't get any enumeration from me from, like decision making and communication and so on, but it's a basic skill to break it down to these ethical principles and apply them when they're needed.
Well, you contributed a lot to the to this Congress. Can you tell us where we can find in the program, where you have found in the program the issues you just addressed, and what you would advise to our audience to have a look at? Can be what they can see tomorrow, or what has been the past 2 days, or in the video on demands?
Yes, thank you. Exactly, video on demand is the catchword. The section has provided a number of really good sessions which give a basic overview and in-depth discussion of a number of ethical dilemmas of implementing palliative care, things like autonomy, but also moral problems, physical restraint, compassion, the vulnerability of the family, the care of the elderly, and the ethical aspects, also aspects of research and state-of-the-art of ethical discussions and research. And we also have a keynote lecture on what was not discussed during the pandemic. So I can only encourage you to, and the audience, to have a look at these video on demands.
Were we sufficiently prepared to have this kind of discussion, you think, Christiane?
Well, I think everybody can watch and learn at any level. But you are right, what we need in the future, and where we also need to take the ethics section and develop in the coming years, is to implement ethical training, palliative care skills training in education. I think this is a big lack. It's still lacking. People don't know enough about the legal background, about the ethical background, and about the skills to proceed in various scenarios and for various questions. And then, of course, to continue the research on basic questions.
Well, thank you very much. I thank you again for your huge contribution to this Congress. And we will now switch to Lisbon in Portugal, where is Pedro Povoa, and he's the chair of the section of infection. Well, this has been a fantastic year for you, I presume, Pedro, with all the infections we have seen all over the world. Can you tell us a little bit from your point of view what you consider as the most important developments over the last 1 to 2 years? And of course, you do not have to restrict yourself to COVID. You have to switch your sound on, I think, Pedro.
Hello, Armand, and all the others that are with me here. Yes, COVID has dominated our almost 2 years. That is almost the age of this disease. And there has been lots and lots of papers on this, mainly on related to infection and the management of the disease. But what I think we learned a couple of lessons. We learned that sometimes using off-label and compassionate use of drugs do not add too much to our knowledge. And so we must learn first and do later, as Derek Angus said in the C19 marathon that the society held in March last year. And with some good trials, then we had lots of good innovations in COVID-19 treatment with anti-infectives, with immunotherapy, and there are still some new drugs that are appearing that hopefully would improve the outcomes of these patients. And also, we treat patients, but again, the vaccines were a huge change of the disease and the control of the pandemic, but is not related directly, obviously, to the intensive care. But also, we learned with the pandemic that the quality of the supportive care, that's how we ventilate, how we make the nutrition of the patients, how we sedate the patients, how we manage all the aspects of the patient is very important. And it's not only the number of ventilators that makes difference, is the quality of supportive care. And I think this has been also a lesson for our specialty, that it makes difference to have good doctors and good nurses taking care of these patients. And that's mainly the reason of different mortality between different areas. And another thing that has been published in the editorial from Mauricio Zacconi and Eli Azoulay is the importance of having some sort of a EU health union. For me, it was a strange, because the waves of different countries were not at the same time. So I have countries with lots of patients suffering a lot, and others without too much problem. And so we could not help the others when we could. And also we did not have the help of the others when we need. I think we should have a different way of, at least in the European Union, to organize our work and to be able to be more versatile and to go to the places where people are needing our expertise.
However, if I may so, if you talk about infections, when I work in the Netherlands and I look at infections that we have, they're quite different from the infections that you see in, for instance, in Portugal, in your country. Can you tell us something about the infections that were, apart from the COVID-19, did we see, was it completely different in the intensive care regarding infectious diseases over the last year? Are there new developments in this respect?
We have mainly, what we observed in COVID is a higher rate of hospital-acquired infections. The causative pathogens were not that different from the others, is much more related to our baseline levels of resistance, but the rate of ventilator-associated lower respiratory tract infections, comparing, for instance, to patients with influenza, was almost the double, and also the rate of bloodstream infection was quite higher. And we had also in Europe, at least in some countries, a higher rate of Kappa, COVID-associated pulmonary aspergillosis, and in some countries, like in India, we had also COVID-associated mucor that could be related to some geographical properties or of the places and humidity or other factors. And but again, what we observed was more a higher rate of hospital-acquired infection, and the bugs behind were more related to what was the underground level or baseline level in each place, and not that different from places to places with COVID.
Mm-hmm. So what would you advise, in view of all these developments, the audience to watch of the Congress, and where can they find it?
I think there are a couple of very interesting thematic sessions and video on demands. One on drug therapy and COVID-19 with people from different areas that would address new antivirals, new immunotherapies, and how you can put them together to help improve the condition of the patients. Also, the issue of bacterial co-infection. I think there's a very interesting presentation on that, because in the beginning, as you well remember, we were treating all patients empirically with antibiotics, and then we end up knowing that the rate of bacterial co-infection was much lower than we expect in the beginning. Also, an update on COVID management, and also with a joint session with the Cs, with the roles of different approaches to the patient, and also finally looking at fungal infections in COVID-19 patients, because probably because of the disease and the therapies, these patients are at higher risk of different fungal infections that could also have a huge impact on their outcomes.
Okay, thank you very much, Pedro, and thank you for your huge contribution also to the success of this Congress. We will now switch to Barcelona, where is Ricard Ferrer, the chair of the Systemic Inflammation and Sepsis. Well, it goes almost without asking that there have been very important developments in the field that you are specifically in, Ricard. So can you tell us a little bit about it, what you consider as one of the most important developments that we have seen in the field that you cover with your section over the last 1 to 2 years?
So hello everyone, hello Armand, and congratulations for the Congress. I think it's being very successful and you are the leader for that. Yes, I think that for this year in this Congress we have been the presentation of 2 main papers, and I think they are both in the opposite side, let's say. One is the presentation of the Surviving Sepsis Campaign guidelines, and the other one is a clinical trial presented this morning regarding a phase 2 trial called Adrenal for adrecizumab in patients with sepsis. And I'm saying that they are in the opposite side because I think Surviving Sepsis Campaign is improving each edition of the guidelines, trying to provide a general recommendation of management of septic patients. So that means grouping all patients with severe infections in a single syndrome and giving us advice how to do this general management. I think this is a great achievement of the last 20 years, let's say. But we are seeing more and more, and especially in the last 2, 3, 5 years, that we need to use this group of patients with sepsis to be the group, let's say the group these patients according phenotypes and endotypes, especially for these trials with this type of molecule, specifically monoclonal antibodies, try to go for a more personalized approach. So
what groups are you thinking of? Sorry for interrupting, but what kind of groups of patients are you thinking of? How would you divide those patients?
Yes, we have seen that different endotypes or phenotypes can explain different outcome, but also different response to treatment. Mm-hmm. And we can use, for example, biomarkers. And this trial I am discussing now, the Adrenal trial, is using a biomarker of endothelial dysfunction, which is adrenomedulin, to select the patient for the trial. So we have on one side the general recommendation for septic patients, but now we are focusing in studying a small group of patients selected by biomarkers, in this case, enrichment the sample for the trial, and then trying to show efficacy. It's true that it's a phase 2 trial, but I think this is the way sepsis is moving in the recent years, trying to have a more personalized approach. In this case, with biomarkers, others have failed because other studies with devices, in this case, try to select patients using endotoxin activity for endotoxin removal. But in this case, with drugs, I think this study is quite successfully showing some improvement in efficacy and open the window for a phase 3 trial. So I think this is the most important change in the approach for sepsis, going for a more personalized approach and using biomarkers and other innovation, because I think not only biomarkers, also big data analysis are helping us also to have a better classification of patients with sepsis.
You were referring, of course, to adrecizumab, the study. Do you really think this drug will be a game changer in the treatment of sepsis, or only in a particular group in sepsis, that you want to separate groups according to some biomarkers? What do you expect of it? Because we have seen a lot of failures over the last couple of years of a very enthusiastic beginning of a new drug. What do you think, Ricard, of that?
Well, I think that most of the studies fail because they don't use prognostic or predictive enrichment. So this study is using predictive enrichment, so selecting patients by biomarkers, so only patients that have high probability to respond to this specific compound, because this compound is acting in the endothelium, and they use a biomarker of endothelial dysfunction for selecting patients. That is very interesting. But what I have seen this morning is that they also use another biomarkers for increase the enrichment, avoiding to include patients for treatment in those that based on another biomarker, which is DPP3, that they could understand from a post-hoc analysis that those patients, if they have high levels of these biomarkers, they are not going to respond. So they expect for the phase 3 trials that using two biomarkers, they can even increase the enrichment of the sample. But it's not going to be a big game changer, as you said, because it's not going to be an approach of one size fits all. It's going to be just for a selected group of patients that I think for these treatments that try to modulate some of the inflammatory response or the coagulation response in patients with sepsis should be targeted, not for all, because we have seen that, as you said, that there is a lot of heterogeneity in the response of these treatments. And if we don't enrich, we are going to miss which patients improve and which patients do not improve. So I think this is the future for sepsis.
Well, thank you very much, Ricard. You already referred to the program, and people who have missed it can look it back as a video. Thank you very much for this contribution. We will now switch to Nicole Juffermans from the section of translational biology, which stands, of course, at the basis of what we will know in intensive care medicine. Well, Nicole, can you tell me, how do you look at it? You're also the editor-in-chief of Intensive Care Medicine Experimental. So tell us a little bit, what can we expect and what can we see in the Congress of these new developments that are in your field?
Yeah, definitely. Well, first of all, you should have been interviewing John Laffey because he's the chair of the translational biology section. But he sustained an accident by car, and he's okay now, but he didn't feel up to an interview like this. So I'm happy as a deputy interim chair to stand in. As you know, the role of deputy will be gone, so it's only interim. So this will actually be the last thing that I do in this role. But yeah, great to talk about translational biology. It's actually a novel section, the founding of which was done in recognition that there may be merit to move away from pragmatic trials towards more precision trials. We just spoke about an example of that. But if you want to do this, this really requires basic understanding of the biology of all the diseases and the dysregulations that we see in ICU patients. So I'm not saying that this doesn't happen. Obviously, great translational research is being done in all sections that are present in ESICM, but the reason that the TransBio group was founded was to have a more focus on the importance of translational research, and also to foster collaborations between sections. So it's really, and this is the main asset of the TransBio group, is that it's cross-sectional. We had our section meeting yesterday, and a lot of people logged in, and it was very clear that these were people with very different research backgrounds. So from cardiovascular, from trauma, from sepsis, from ARDS, everybody was there, let's say. So I think this really shows that we are a cross-sectional section within ESICM. And I think it's good to talk more about the aim. What do we want to do? What do we want to reach with this section? And that is, as I said, to increase the collaboration between the sections in order to write better papers together, and also to apply for grants and also within the European arena as such. Yeah, and you were asking me how this reflects on the Congress. For us, it's really natural to work closely together with the sections. So this is what we did in preparation of the Congress. And I think we usually were successful in doing this. We have a lot of video on demands, and these are great sessions. And I'll just give you an example of one of the sessions that we did with the use of these video on demands. And that's in collaboration with the acute respiratory failure session, in which we talked about the funding of the next generation of treatments in ARDS. And these video on demands by a lot of people really gave us the chance to, to discuss what is the problem. Do we need to redefine the syndrome? What about biologic heterogeneity? How do we phenotype ARDS? And then from there on to novel therapies. And yeah, that's a great example. We did the same for sepsis and also in trauma. We worked together with a TEM session in which clinical-oriented people talked about the standard of care of management of trauma, and the more translational people talked about potential novel interventions. So I think there was really great interaction with all the existing sections that are already present.
Well, I think you just reflected very well where we worked on very hard over the last years to have more interaction between the section because, well, a patient is never a patient with a single organ or a single disease, and there are more things to happen. So we come now to the end of this session. If I may ask you all to give some advice to the audience what they should do in the coming time with respect to the Congress. What kind of advice would you give them from your perspective? And perhaps I can start very shortly with Nicole to give us an advice.
Well, I would urge people to watch the session about the emerging therapies in 2030, in which we really stuck our head out and trying to see, okay, what direction is ICU treatments taking. So have a look there.
Okay. And Ricard, if I may go back to you, what would be your advice for our audience to do?
There is a session on sepsis prediction using machine learning and big data that I think it's, for me, it's very interesting and exciting my neurons for future research.
Thank you. Pedro, if you go on this topic, what would be your specific advice to the audience?
I think they should look at what it is the most interest of them related to is the topic that they like most. But maybe concerning anti-infectives, I think one very nice session is from the next called Everything You Want to Know About Anti-Infectives, because when you use it every time, we think they are very, very good and safe drugs, but sometimes they are not. And so we should always learn a little bit more about this.
Okay, so now then the final word is for Christiane. Can you hear me, Christiane?
Sorry, yes, my micro. Actually, I must say I'm very pleased that ethics is part of very many undeclared sessions, presidents, special sessions, bringing Ili Azulai is very strong on that, bringing humanization to the ICU. So if I can only encourage the audience to go to the VODs, the videos on demand, and look at the special questions there, I'm sure they will find one or two which really answer their specific questions or get them to more thinking or enthusiasm for this kind of approach to improve patient care.
Okay, well, I thank you all very much for giving us this information and these details. And then we come to the end of this session. I really hope to see you again tomorrow, a little bit earlier than you are used to. So see you again tomorrow.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. welcome to the second hot topic of Lives Digital 2021. I am very excited because again today we have a premiere of a study that has just been completed. I see that many of you are connecting to our platform. I remind you, please use the chat for sending comments or for asking questions. We will be monitoring this and try to answer all of this at the end of the presentation. So without losing any more time, I would like to welcome Professor Bruno Levi. Bruno Levi is a professor of intensive care medicine, the head of ICU in Nancy University Hospital, head of a research team dedicated to shock. The main topics of his research are vasopressors, cardiogenic shock, ECMO, inotropes, lactate. And indeed, we are going to listen now to the first time these results are disclosed to an audience about hypothermia in ECMO. Bruno.
Ladies and gentlemen, good afternoon. My name is Bruno Levi, and I work in Nancy in France. And it is a great pleasure for me to present for the first time in the Congress the results of the HYPO-ECMO study, the effects of moderate hypothermia on mortality in cardiac shock patients rescued by VA ECMO. So first, and as you know, hypothermia induces many effects on the cardiovascular system, a decrease in heart rate and a decrease in cardiac output, which is proportional to the decrease in heart rate, no change or a moderate increase in arterial pressure, an improvement in cardiac contractility and a decrease in myocardial oxygen consumption, which is higher than the decrease in cardiac output. And this picture illustrates the main mechanisms implicated in the protective effect of mild hypothermia against ischemia reperfusion injuries. And this representation was initially addressed to brain ischemia reperfusion, but it may be for a large part be applied for all organs. And as you can observe, hypothermia acts on many pathways. This classical figure illustrates the so-called all cardiac shock paradigm, mainly centered around loud cardiac output syndrome and cardiac congestion. And on the left part of the slide, the new cardiac shock syndrome, which associated, of course, a decrease in cardiac function, but also a picture of sepsis-like syndrome. And this patient may have normal or increased cardiac output and a marked decrease in diastolic pressure. The most recent paper concerning hypothermia using cardiac shock comes from our team, and in patients with cardiac shock after acute myocardial infarction, they did not find any differences in cardiac power index or in other hemodynamics parameters. Nevertheless, this was only a pilot study, not powered for mortality, and that did not take into account extracardiac properties of hypothermia. So, in the situation of refractory cardiac shock, the role of a VA ECMO, which is more a circulatory assistant rather than a cardiac assistant, is to break the vicious circle or refractory cardiac shock. So, in increasing blood flow to the organs, VA ECMO hastens organ ischemia and decrease shock-associated inflammations that led to vasoplasia. Of course, it is necessary to use it before irreversible organ failure. And you can see here, hypothermia in this situation may act at different timing and different pathways during cardiac shock evolution. And finally, we perform a model of ischemic cardiac shock in pigs, and we compare normothermia to hypothermia, and we found that moderate hypothermia was associated with, and for the same global hemodynamics, less fluid and less norepinephrine, a faster lactate clearance, a better cardiac function, and a better vascular function. So we perform and we design the HYPO-ECMO trial, because despite the current rise of ICT comparing standard therapy to standard therapy plus ECMO, ECMO use during refractory cardiac shock is still increasing worldwide, and we think that it is now urgent to determine the best approach to optimize such promising therapy. And the HypoECMO study was performed to address the hypothesis that an early use of moderate hypothermia, 33 to 44 degrees, compared to strict normothermia, 36 to 37 degrees, could improve mortality in patients with cardiac shock receiving via ECMO. The current recommendation is to maintain normothermia. So the study was a multi-center randomized control study. The primary endpoint was 30-day mortality, very simple inclusion criteria, intubated cardiac shock treated with via ECMO, and some non-inclusion criteria. The main were refractory cardiac arrest, ECMO for LVAD or heart transplantation, or uncontrolled bleeding. Here, the design, the patient had to be included within the first 6 hours after via ECMO initiation. Moderate hypothermia was induced through the heat exchanger of the via ECMO device and maintained during 24 hours, followed by a progressive reheating and maintained in normothermia until 92 hours after study inclusion. And the normothermia was maintained during the 92 period. The main endpoint was primary endpoint was 30 days mortality, and the main secondary endpoints were first a composite endpoint of death, cardiac transplant, stroke, or escalation to left ventricular assist device at 30, 60, and 180 days. Mortality at the same time via ECMO duration, the duration of mechanical ventilation and ventilatory 3 days, the renal replacement 3 days, and of course safety endpoints, which are bleeding and sepsis. The statistical analysis, we anticipated a mortality of 50%, so the sample size was calculated, 167 patients in each group, to detect a 15% absolute difference in favor of the hypothermia group. We perform an adjusted logistical regression and a post-hoc Bayesian analysis. Here's a flow chart, and as you can see, more than 700 patients intubated and treated with ECMO, and we included 344 patients in the study. An important point is that the temperature control was strictly respected in both groups, the normothermia group and here the hypothermia group. The main results, the primary endpoint, all-cause death at 30 days, and as you can observe, at 30 days, 71 patients, which is 42%, the moderate hypothermia group, here in blue, and 84 patients, 51% is the normal thermia group had died, and this is not statistically significant, and the results were unchanged after multivariable adjustment. Some interesting results concerning secondary endpoint, and you can see that the composite endpoint, there was an higher incidence of the composite endpoint in the normothermia group, and that patient treated with hypothermia has less days with organ failure and less replacement, renal replacement therapy, which is also an important point. Concerning the safety endpoint, the same incidence of severe or moderate bleeding, more transfusion under via ECMO in the moderate hypothermia when the patient was transfused, and the same incidence of infection globally, which is surprising, and less infection, for example, less bacteremia in the hypothermia group, which is also surprising. Here, the result of the Bayesian analysis, and you can see, to summarize, that in all scenarios, the posterior probability of mortality benefit with hypothermia was higher than 85%, and it was higher than 90% with the moderately enthusiastic probability. So some study limitation, of course. We included only intubated and sedated and mechanically ventilated patients. So this is a limitation of the applicability of our findings to other patients undergoing via ECMO. We included patients with cardiac shock of all etiologies, of a majority of cardiac shock etiologies, but this was a very pragmatic study, and it is very, very difficult to include patients with only one etiology, on the exception of acute myocardial infarction. Approximately 50% of our patients experience a cardiac arrest previous to ECMO run, but survivors are all survivors are in CPC 1 or 2. And finally, even though this is the largest via ECMO randomized trial conducted to date, the study was underpowered to statistically detect an 8 to 10% survival benefit with hypothermia. So, ladies and gentlemen, my conclusion: first, early application of moderate hypothermia for 24 hours does not increase survival compared with strict normothermia in patients treated with via ECMO for cardiac shock. Moderate hypothermia was associated with a lower risk of the composite endpoint at 30 days, and was also associated with more days alive and without organ dysfunction or renal replacement therapy. And the rates of hemorrhagic and infection events were similar in the two groups, with the exception of more bacteremia in the normothermia group. Thank you very much for your attention.
Thank you very much, Bruno, for a very interesting presentation, and actually some results which I would find at least controversial. I'm sure there will be questions about this now. I would like to welcome you back on stage, but also to welcome Adrian Wong. Adrian, hello there. Adrian is a friend. He's not with us here in the TV studio, even if he's part of the executive committee of the European Society of Intensive Care Medicine. Indeed, he is the chair of the Social Media and Digital Content Committee, and has done a tremendous job over the last 12 months and to keep really the activities of the society in what we define almost like a TV for intensive care. So hello, Adrian, and hello, Bruno, again.
Hello. Hello. Hello, Bruno. Hello, Maurizio.
Nice to see you. Adrian, can I maybe start with you? You had a chance to look at the results briefly before this presentation of Bruno. Do you want to give us your comments about the study?
Delighted to. First of all, congratulations, Professor Levy and your team. As we would all know, such a trial, undertaking such as this one, requires lots of hard work, lots of perseverance, so congratulations for completing the study. On to a short summary of the study, if I may. So, moderate hypothermia for cardiogenic shock rescue by veno-arterial extracorporeal membrane oxygenation, a randomized control trial, or the HypoECMO trial, we'll call it for short. Now, what this trial attempted to do was to answer the question, does early use of moderate hypothermia, 33-34 degrees, compared to strict normothermia, 36 to 37, could it improve mortality in patients with cardiogenic shock receiving VA ECMO? And the patient they included in this study, or the patients of interest, are those that with refractory cardiogenic shock. Primary outcome, one month mortality. You've heard the study design, but it's a randomized controlled trial, about 160 plus patients in each arm. 160 received hypothermia control versus about 160 in the normothermia group. It took 3 years to complete, over 20 intensive care units across France, so not a small undertaking. You've heard the results, primary results, no difference in mortality at 1 month. That's a bit disappointing, a bit surprising maybe, and I'm sure we'll get into the discussion for it later based on, and I'm sure we're going to touch on all the trials talking about hypothermia in the past as well. But the headline is that moderate hypothermia in patients with refractory cardiogenic shock, moderate hypothermia does not seem to improve mortality.
Thank you, Adrian. However, I wouldn't like to be, or maybe I would like to be, the editor handling this paper, because I admit that when I looked at the Kaplan-Meier curve, even if it's not statistically significant, and then the Bayesian analysis, I seem to see a signal there. Now, Bruno, what was your perception and the perception of the researchers when you've seen these results?
Thank you, Adrian. Thank you, Maurizio, for the comments and for the question. Of course, we were a little bit disappointed, and if you remind the earlier study that concerned VV-ECMO, it's called the most positive negative studies. And of course, we observed only a 9% reduction in mortality. But my perception is that we have to consider other very important points. The first point for me is that hypothermia in via ECMO patients, and especially in patients with very high hemorrhagic risk, such, for example, patients after cardiac surgery, hypothermia was not associated with safety issues. We did not find any significant differences for sepsis or for hemorrhage. The second point is that it's very, very simple to implement hypothermia in patients with via ECMO because we use the heat exchanger of the device. So it's inexpensive and simple. And so we have to keep in mind also the result of the TTM study that finds the same type of result. No differences in mortality, but also similarly no differences in safety issues on the exception of arrhythmias. But arrhythmias are less important in patients with the hypo. So my opinion is that we have to move towards more personalized medicine, and I think that in some patients it might be interesting to use hypothermia in this setting. For example, if we look, and it is not in the presentation, the result of subgroup analysis and the forest plots analysis, we observe a 70 decrease reduction in mortality in patients with very elevated lactate level, higher than 5. 13% reduction in patients with cardiac arrest, 44% versus 57%, or 13 reduction of mortality in patients with less than 16 years. So we may discuss the use of hypothermia in these patients.
Thank you. We have a lot of questions and comments actually that are coming. One that I see is how quickly was the target temperature reached in the intervention group? Sigung Olesania is one of our social media person. He's very active at the moment. He's asking this question.
Very, very good question. So it was very, very fast because with the heat exchanger of the via ECMO, it's in less than 1 hour the patient was at the temperature. So it's very, very easy to decrease the temperature very, very fast. And we induced the hypothermia as soon as the patient was included.
So, Bruno, I have a question. Well, maybe Adrian looks for other questions in the chat. But can you help me to understand better the physiological rationale for it? Is this the conjunction with ECMO, or is this hypothermia that could work in patients with cardiogenic shock? Let me elaborate a bit more. Did you control also the time in which you define cardiogenic shock? Because often ECMO is a salvage therapy, and what was the time range of patients from definition of cardiogenic shock to ECMO, which as we know is a salvage therapy?
Okay, thanks Maurizio for the question. First, patients have to be included after at the higher time is 6 hours of ECMO after via ECMO initiation. So it's very, very early in the course of via ECMO. I do not have any data concerning the pre-ECMO period, but we use a very pragmatic, it was a very pragmatic study, and we included patients in the way we use ECMO. Considering the pathophysiological, it's a combination of the effect of hypothermia on ischemia reperfusion and via ECMO. Via ECMO are likely the most severe patients on terms of ischemic reperfusion injury, because they have short reperfusion due to the treatment, epinephrine, norepinephrine, dobutamine, local reperfusion at the heart levels, and after shock aggravation, and massive reperfusion with via ECMO. So for me, it's really very good model of massive ischemic reperfusion injury. Of course, we also have in mind the fact that in a majority of studies, approximately 50% of the patients in cardiac shock experiment a cardiac arrest during the course of cardiac shock. And it was also the case in our study. So we would like to combine the protective effect of hypothermia, the same when, for example, for cardiac arrest, and the protective effects of hypothermia in ischemic reperfusion at the global level, the heart, the brain, the vascular function, etc., etc. Concerning the preliminary results, there is some lack of data. The only data we have is a meta-analysis. We found that patients who were treated with hypothermia during cardiac shock had a better cardiac function a long time after.
Thank you, Bruno.
I'm going to pick you up, Bruno, on a couple of points that you've mentioned in both your answers, which is, in this study, what you've tried to do is to bring cardiogenic shock under one umbrella. And the underlying etiology of cardiogenic shock is indeed very, very variable. So, and you've mentioned it in the limitations in your manuscript as well. So can you comment about the different subgroups of under the umbrella of cardiogenic shock? Did you see a difference between them?
Yeah, thank you, Ariane, for this very good question. First, in the presentation, I did not present the population characteristic. I apologize for that, but approximately 40% of the patients were myocardial infarction, 40% were ischemic cardiomyopathy, and 50% of the patients were cardiac shock post-cardiac surgery. After, it was a mix of etiology, on the exception of poisoning and out-of-hospital refractory cardiac arrest, which is really another disease. So we did not find any differences between these etiologies, and I can just comment. It's very, very difficult to perform a study on via ECMO patient, which is a rare disease when compared to myocardial infarction, for example, on the exception of acute MI. And there is currently at least 3 or 4 studies ongoing that compare traditional strategy versus early via ECMO in acute MI. But the first of the study will be finished in approximately 4 to 5 years. So we decided to perform a pragmatic study for patients in which we use via ECMO today. And we want to test and to improve the strategy in which we use the ECMO for this patient.
Another question from the audience is regarding your selection of outcomes. So from what we know of temperature management, the goal has always been to improve good neurological outcome. So not just patients not dying, patients recovering to a good quality of life. Again, any neurological outcome in this study that you looked at, and perhaps was there a difference in the subgroups of those, if you did look at it?
Yeah, it was not the main aim of the study, and this is a very, very good point. So what we found is that concerning the survivors, all the patients who survived and that had experienced a cardiac arrest were in CPC 1 or 2 after 1 month. That means, and it shows that for example, that the neuroprognostication was performed, and at least it shows that some patients were withdrawn of a measure of rate of life. But the result, the complete result, is that survivable patients who had a cardiac arrest are in a good neurologic outcome. This is not very surprising. And if we look at subgroup analysis, we found a difference in 13%, 44% of mortality versus 57% in patients with cardiac arrest. This was predefined subgroup, but of course it's only a small part of the patients that were included.
Can I ask you to elaborate on that, Bruno? Because I was also surprised by the fact that you had a significant proportion of patients with previous cardiac arrest, which clearly they may have a different reason for a poor neurological outcome and for the possible benefit of hypothermia, even if recent studies, of course, have questioned that too. Did you control, at least in the inclusion criteria, things like low flow time or no flow time of the cardiac arrest patients?
Yeah, yes and no. First, Mauricio, thank you for the question. It is not surprising because if you look at all the study for patients that treated with the patient with cardiac shock, we found always approximately 40 to 50% of patients that experiment with cardiac arrest. We just excluded patients with cardiac arrest higher than 45 minutes. Maybe it's long, but you know it's usually cardiac arrest in the coronary lapse, for example, witness cardiac arrest with the cardiac surgeon very, very close, and we put the ECMO very, very fast. So even in patients with very low flow, but no flow, we experiment good survival.
And are you planning, or are you also analyzing data on longer term follow-up? Like the 30 days mortality is, of course, your primary outcome there, but are you going to have data also 90 days? Yes, or?
Yes, it's in the paper, and we follow the patient at 6 months, and the results are quite the same. The only difference is that patients treated with moderate hypothermia had less renal failure and less dialysis, but no differences for mortality. And you know, it's very complicated to mind that in a disease that experiments very, very high mortality at 30 days to hope for better results at 6 months.
Well, Bruno, we are almost wrapping up, and I know that Adrian has one probably last question, but before I pass to Adrian, thank you for your answers, but also I would like to congratulate all your research team, because to perform a study on ECMO patient and a randomized control trial, I think it's an extraordinary effort, and really thank you all. Even showing that we can do these kind of studies in intensive care, it's really impressive. Adrian, I leave to you the last question.
So let's round it up for our colleagues listening in then. You've done the study. So my question to you is, what now? What now for the next patient that comes into our intensive care with cardiogenic shock? And what now with regard to the next research question?
Thanks, Adrian. We discussed previously this question, and my answer is very simple. It's my perception. For the next patient, I will use moderate hypothermia. For all the reasons I previously mentioned, it's safe. There is no safety issues. It's inexpensive. It's very simple, and it's very, very controlled. And if we look at for example, the editorial which were published with the TTM2 trial, the editorialist wrote, you can use 43 degrees, you can use 46 degrees, you can use 47 degrees. First point. And I don't think that there is a place for a new study. I'm very confident with the Bayesian analysis, which is now a new tool to deal with this study with intermediate results. And the Bayesian analysis is really, really in favor of moderate hypothermia. So my units for this kind of patient, intubated, very severe patient, and maybe more in patients with high lactate level, with cardiac arrest, and young patient, we use moderate hypothermia. But it's my opinion, of course.
Well,
thank you very much.
I have to say it was a wonderful discussion, and again, also the challenges of analyzing the data, as we see with standard frequentistic statistics and the Bayesian statistics, but importantly, you planned everything a priori, and I think you showed us very important results. So congratulations on the study, Bruno. Thank you very much, Adrian, and Bruno, of course, good luck now with publishing these results that are very important.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.